A very good evening, everyone. I'm Dr. Deepika from the medical team at BSV, and I'm delighted to welcome you all to Perfection Fertisphere by ISAR Symposium 8.0. Please note that there is certificate of attendance at the end of today's session, so we encourage you all to stay with us throughout the program. Today's discussion focuses on an equally important and often under-addressed area in reproductive medicine, that is optimizing embryo transfers. We look forward to an engaging, insightful discussion with our distinguished faculty and expert guests today. To set the tone, it is my pleasure to introduce our convener for the evening, Dr. Monica Singh, a trailblazer in the field of reproductive medicine. Ma'am currently serves as President-elect Bhopal Obstetric and Gynecological Society, Founder President ISOPAB Bhopal Chapter 2024-27, National Executive Member ISAR 2024-27. She is also the convener behind several impactful academic initiatives, including the ISAR Perfection Series, the Foxy Symbiosis Series, and the Synergy Academic Club. We welcome you, ma'am. Over to you.
Thank you, Deepika, and thank you, Team BSV, for providing us this platform for showcasing our work through ISAR. Can I please have the first slide? So today we are gathered here on the 26th of December, just one day after Christmas, to get back to what we love the most, that is studies. So it's like always, I think gynecologists love to get together and talk about their work, and fertility specialists are one step ahead. Mala ma'am is nodding in agreement, and Keshav is also smiling that today we already are on the at the end of the year 2025, and we end with nothing better than embryo transfers, because once we end the year with an optimum embryo transfer and get a good pregnancy, a viable pregnancy in early in Jan, it sets the tone for the whole year. So we are proud to present this webinar in association with Indian Society for Assisted Reproduction, and we have a galaxy of dignitaries in front of us. We have our President ISAR, Dr. Amit Patki, our Secretary General ISAR, Dr. Asha Bakshi. We have chief guest as well as keynote speaker, Dr. Madhuri Patil. We have special guests for the evening, Dr. Archana Baser and Dr. Meenu Agrawal. And we have our guests of honor, Dr. Mala Arora and Dr. Keshav Malhotra. So I'll just take a minute to walk you through the program. Our scientific program today has been curated with care in order to encompass both the embryological and the clinical aspects. So for the first 30 minutes, we listen to a stalwart speaker, Dr. Madhuri Patil, who will be deliberating on the clinical strategies for success in embryo transfers. And this session will be followed by an equally exciting embryological perspective on the same subject by Ashwini Kale, who will be telling us what happens in the lab and how we can start optimization right from the embryology lab. This will be followed, because these are two heavy lectures, there'll be so many doubts in the mind of our audience and our postgraduates. So troubleshooting in embryo transfer to maximize your IVF success will deal with certain difficult, sticky situations in the lab as well as in the OT, where you get stuck in embryo transfer and sometimes you blame your embryo transfer for that elusive pregnancy, not having that elusive pregnancy. Moderated by myself and Dr. Randhir Singh. And we have experts and panelists drawn from all over India. And you can see the galaxy we have over here. And we sure to have a very exciting panel discussion is always the highlight of this scientific symposium. So please stay on till the end and enjoy this. So coming to the welcome, a formal welcome, I would request everyone to welcome our dignitaries of ISAR who have given us this opportunity to present this program in association with the Indian Society of Assisted Reproduction. Our President, Dr. Amit Patki, sir, and Dr. Asha Bakshi, our Secretary General. I think Madam and Sir will be joining very soon. So we will wait till they join. We all know the great work they've been doing in ISAR. And we thoroughly thank them from the bottom of our heart. So next, I would like to welcome our chief guest for the evening. Dr. Madhuri Patil, Madam, has joined us. Good evening, ma'am, and a warm welcome to you, ma'am. I'm so grateful that Madam has not only accepted to be the chief guest for today, as she's also the keynote speaker for the first talk we are going to have today. Dr. Madhuri Patil is a well known name in the field of reproductive medicine all over India. Right now, Madam is holding the key position of Vice President of ISAR, and we look forward to a very, very exciting, session with the vast amount of knowledge and precision in her talks, which I've seen Madam talk many times in my program, and every time those talks have been recorded and re-listened to many times by students in order to, really grasp the depth of her knowledge in every topic that she touches upon. We know a large amount of work being done by Madam in Bangalore, but sitting from her office, she is editing Fertility and Sterility, the official publication of ASRM, where time and again we get exciting articles. Madam is the chairperson of Aspire Special Interest Group Reproductive Endocrinology, vice president and founder member of the PCO Society of India, vice president of ISAR, board member of Androgen Excess PCO Society, member of Education and Journal Committee of Aspire, country representee to Aspire, founder member and president of Fertility Preservation Society of India, again a topic she is very passionate about, past editor-in-chief of JHRS, an official publication of ISAR, governing council of member of ICOG, and has won awards like the Duru Shah Lifetime Achievement Award from ISAR in 22 and Vidya Vibhushan Award from ICOG in 21. Madam is the founder chairperson of KISAR, and I've just spoken to Anuradha Kar about Madam yesterday or day before yesterday, and she is all praises. She says everything, every step in KISAR is done under Madam's guidance. Principal and course coordinator and examiner for fellowship and certificate course in reproductive medicine at Rajiv Gandhi University of Health Sciences, Karnataka, member of International Reproductive Medicine Research Network with several publications in national and international journals, author of several chapters, and editor of several books. We are honored to have you amongst us, Madhuri Ma, and it'll be lovely to have blessings from you.
Thank you very much, Monica. I don't think that introduction was really necessary. So I congratulate you for running the Perfection series for ISAR. And I know that in the last 2 years, Dr. Amit Patki and Asha Bakshi have done a lot of work in ISAR. They've had several webinars as well as several conferences and masterclasses. And I think masterclasses are the best according to me, because we deal with a single subject for 2 days, and the take-home messages are also much more than in a general conference. Plus, the crowd is less, and therefore, people can ask their doubts and also clear their doubts. So, I think the master classes designed by Amit and Asha were really well taken, and they were really, I think we had almost about 11 of them. And I think y'all are doing the webinars almost every week. I think I have the lost count of the webinars done. And I think this topic which you have chosen, optimizing embryo transfer, is very good, because I think that's the final step, which is going to result in a successful IVF. And I hope that people will have a lot of take-home messages from this webinar on optimizing embryo transfer, and which deals both with the clinical as well as embryology part, as well as a panel discussion, which will help people understanding it in more detail. So I'm wishing every success for this webinar, and I hand over to you.
Thank you. Thank you so much, Madhuri ma'am, for your words of wisdom. And now I proceed with the program by welcoming our special guests for the evening. The special guests of Perfection series are special because of their position, their work in ISAR, their passion for teaching, and because they hold a special place in our hearts. So we welcome Dr. Archana Basen ma'am, very popular in MP, She is at present the chairperson of MP ISAR and the immediate and the past vice president of Foxy. Madam is a well-known figure in the field of reproductive medicine with a passion for sonography. She is also the Guinness World Record holder for having removed the largest uterine tumor. Madam has been the vice president of Foxy in the year 2020, organizing secretary of AICOG 21, a very super successful conference in Indore, fellow representative of AICC RCOG West Zone, and Imaging Science Committee Chair, CEFOG. Madam has led Foxy from the front as Chairperson Imaging Science Committee, organizing secretary of the hugely successful ISAR 2016 at Indore, as well as ISAR 2023 at Bhopal, and the managing committee member of ISAR, IAG, and ICOG. We wish Madam all the best for her endeavors, and we would love to have blessings from you, Madam.
Thank you. Thank you, Monica, for having me here on this program, which you are doing under leadership of dear friend Dr. Amit Patki and Dr. Asha Bakshi. I think the topics you and Randir are curating for this Perfection series are really wonderful topics. And the gathering of speakers, I mean, the galaxy of stars you are picking, hand-picked speakers, I think it is wonderful, wonderful. You have Madhuri, you have Meenu, Dr. Mala, Dr. Keshav, yourself, and Randir, and many from all over the India. You are gathering them and you are spreading knowledge. Actually, you are perfect. I should say your perfection series and the topic today, embryo. Like the thing, the last thing, which is the last part, but the most important part of the IVF, that is implantation and embryo transfer. It is taken very lightly. Okay, I've done the ovulation induction pickup, and sometimes, okay, embryo transfer is something which really need a great depth of understanding and very careful, because that is going to give you the result. So the topics chosen are wonderful, and I wish you a very good webinar today and all the success for your future endeavors, which I keep getting that you are contesting for managing committee, ESAR, and you are stepping into Foxy as well. So all the best to you. And I'll use this platform for just 1 minute for myself as well. I'm contesting for Foxy President 2026. And please support me and give me your blessings. And to my dear friend, Dr. Asha Bakshi as well, for Vice President of ESAR. So thank you very much and all the best. And congratulations for a wonderful topic and really good speakers.
Thank you,
Thank you.
Archana ma'am. Thank you.
Thank you, Archana ma'am. And you're always encouraging and very supportive for all our efforts, ma'am. We juniors really benefit from your support and encouragement. Next, I would like to invite and welcome our special guest, Dr. Meenu Agrawal, ma'am. Is Madam there? Madam is yet to join. So, Ankita, could you please place a call to Dr. Meenu Agrawal, Madam? And next, I would like to come and invite our guests of honor for the evening. Our guests of honor for the evening are Dr. Mala Arora ma'am from Faridabad and Keshav Malhotra, Vice Chair Embryology, ISAR. Can I have their CVs, please? Dr. Mala Arora is a person we all look up to. In fact, the master classes that Madam was mentioning, Madhuri ma'am, one of the great master classes I attended under Dr. Amit Patki's leadership was on RPL. And we extensively discussed this topic. And this keynote speaker here, who really opened up our eyes on the role of probiotics and prebiotics, was Dr. Mala ma'am. And RPL is Madam's passion. She has written books on it. She is a very senior consultant OBGYN from Faridabad, Delhi. She is heading the Noble IVF Center and is also consultant at Fortis La Femme, Delhi. She is internationally trained senior gynecologist with more than 45 years of experience globally recognized for her expertise in RPL, infertility, and high-risk pregnancy. She is an author, an international faculty, avid academician. We can see how Madam has gathered her coveted degrees from all over the world. She is an MRCOG. She's also got degrees from the UK and Ireland. And apart from her areas of expertise, she also is an expert in hormonal, genetic, and immunological evaluation because these have a great role to play in RPL. She promotes comprehensive women's health care through her expert practice. And Madam has been the editor-in-chief of Recurrent Pregnancy Loss multiple editions with several book chapters, several national and international presentations.
You, dear.
And
Thank you so much.
thank you, ma'am, for joining
Thank
us
you.
today.
Thank you, Monica. I really am impressed. You conduct the Perfection series to perfection. And as we all know, success in IVF is like a conveyor belt where each step has to be done to perfection to receive the reward of a successful pregnancy or take home baby. And as everyone has mentioned, the embryo transfer is not only the last step, but is the bottleneck that we face because we need to learn a lot more about the timing of embryo transfer, the uterine environment, in order to minimize the miscarriage rate and maximize the clinical pregnancy rate in IVF. So with that in mind, we have registered the Indian RPL Foundation, and we wish to invite more members into the foundation. We have also launched the RPL Journal. It's the International Journal of Recurrent Pregnancy Loss, where researchers from all over the world can come together and help us decode this huge bracket of unexplained RPL. And one of the areas that we are making progress is chronic endometritis, which can be treated very successfully with antibiotics and probiotics and prebiotics. Of course, there are other progresses that we have made. One of them is in genetics, better genetic testing of the embryo, and also better mRNA testing of the uterine endometrial decidual environment. So I really am delighted and honored to be a guest for your program. And you, Monica and Randhir, are exemplary couple dedicating your life not only to clinical practice but also to teaching and spreading awareness. And I wish you both all the best. And I wish all the best to both Asha for her upcoming elections in Isar and Archana for her upcoming elections in Foxy. Thank you so much for having me on the program.
Thank
Thank
you.
you,
Thank you.
Malavan. Thank you.
Thank you. We are so grateful for your presence, ma'am, and always your support. Uh, our guest of honor is Dr. Keshav Malhotra. So I would take the opportunity to present before you our Vice Chairman ISAR, Dr. Keshav Malhotra, Director, Rainbow IVF, and done wonderful work throughout his career for Aspire, for ISAR, ISPAT, done some wonderful work in ESHRE as well. He is the executive committee member of Alpha Scientists of ACE and ISPAT. ESHRE 5 2021, Budding Embryologist of the Year, awarded by Economic Times in 21, Business World 40 Under 40 2023, and Fellow of the Indian College of Reproductive Medicine, which was started by Dr. Nandita Palshetkar in 2024. Welcome, Dr. Keshav. You have been a speaker in our program, and you have very many fans in our group. So the stage is all yours. Today you are here as a guest, and we are delighted to have you.
Thank you, ma'am. I think it feels slightly awkward to be a guest of honor amongst the galaxy of speakers and faculties that you've actually gathered for this wonderful webinar today. Um, I think the topics that you choose are absolutely wonderful and crucial for any budding fertility specialist. And the way that it's been conducted is absolutely superb. I think today's topic, which is embryo transfer, is probably of more importance to us because it's generally considered as the last step of an IVF cycle. And even though it looks easy on paper, it carries the entire weight of the cycle. And every decision that the clinic makes, be it the clinician who would decide on the stimulation and the preparation of the endometrium, to the embryologist who will decide the culture conditions and the handling of the embryos, and also the biology of the patient, everything comes together and culminates at this one step, and therefore it becomes probably one of the most crucial steps. There's no one better than Madhuri ma'am to actually speak on the clinical side, and with all her vast experience, I think she will be able to give us so many key insights into the techniques of embryo transfer, the preparation for embryo transfer. And again, there's no one better than Ashwini to speak on the embryology side. And I think that's one thing that I really appreciate, that the embryologist perspective on this particular technique is also considered a part of this wonderful initiative. And of course, both of you are going to cover the troubleshooting aspects, and it would be a very interesting panel discussion to hear. With this, congratulations to both you, ma'am and sir, for this wonderful webinar, and really looking forward to the discussions.
Thank you, Keshav. Thank you. And now your little whiteness in the beard looks like that remembers your papa.
Some experience has come
Yeah.
finally.
Thank you.
So thank you, Dr. Keshav, for being there and for teaching our audience, teaching us. We have so much of knowledge to gather from our embryologist friends that today only I was discussing with Ashwini that they are a very, very vital step of our fraternity, embryologists. So every ISAR perfection, we always make it a point that if not 50-50, at least there should be a distribution of 60-40 between our clinical guests and our embryologist guests. Thank you so much, Keshav. And I would now move on to our team, because any good work requires teamwork. Without a team, you are nothing actually. So whatever you see, whatever I am presenting has been curated by all these wonderful team members. My co-convener, Dr. Randhir Singh. My other conveners from ISAR, Dr. Randhir, we all know him as, my support and my co-convener responsible for doing the very successful ISAR Bhopal and managing committee member of ISAR. We are very sincere and we are very passionate about doing our work in ISAR. We also are a part of the PCPNDT and ART Surrogacy Board of Madhya Pradesh. So in MP, we have got very streamlined rules for surrogacy. As a result, we are able to do many cases here. Thank you, Dr. Randhir. I would like to now introduce our co-conveners, Dr. Garima Sharma, Dr. Manisha Bajpai, and Dr. Neelam Bise. These three wonderful ISAR managing committee members are a vital, integral part of the program, and they come up regularly with ideas which I can put into reality and present this show in front of you. I also have coordinators from Bhopal, Dr. Ankita Upadhyay, and Dr. Payal Raghuvanshi and Dr. Purva Bhatkur. All three are dynamic ladies from Bhopal, professors in medical colleges, heading IVF centers, who are calling you up regularly, putting the program, the bits and pieces together, and putting up this great show in front of you. Thank you, Ankita, Payal, and Purva. And now we straight away move to our session number 1, for which Madhuri ma'am is waiting to speak in. And the session number 1 will be conducted by Dr. Ankita Upadhyay. Over to you, Ankita. Ankita, are you there? Ankita, are you there? Okay, I think I'll start.
Hello. Hello.
Ankita, are you there?
Yeah,
Yes, ma'am.
Please
Yes,
start.
ma'am. Yes, ma'am.
Yeah.
So we now begin the first session for the day. That is the art of embryo transfer. The faculty for this is Dr. Madhuri Patil ma'am, as well introduced by Dr. Monica Singh ma'am. She is an expert in the field. I now invite the chairpersons for the session, The first chairperson for the session is Dr. Randhir Singh, sir. Sir actually needs no introduction. Sir is an ASHRAE certified embryologist, and sir is the director at Bhopal Test Tube Baby Center, Bhopal. The next chairperson for the session is, please change the slide, Dr. Kalyan B. Barmade. Sir is a highly, sir is a expert in the field of infertility, and sir has been a secretary of IAG in 2023 to 24. Sir has been chairperson for infertility committee in amongst 22 to 24. Sir has been chairperson for Public Awareness Committee in 2019 to 22, and Sir has been executive managing council member of several conferences that had been held in the past years. We are honored to have you, sir. We welcome you. The next chairperson for the session is Dr. Manjunath CS, sir. Sir is a reproductive medicine consultant. Sir is the Deputy Medical Director at Builder Fertility and IVF, Baby Science IVF. Sir has over 17 years of experience in the field, and he has an experience of over 20,000 plus IVF cycles. Sir has several awards to his accolade, and Sir is a great expert in the field. We welcome you, sir, and we are honored to have you here. I now request Dr. Randhir Singh, sir, to take the pleasure to introduce our speaker, Dr. Madhuri Patil, ma'am.
I don't think, I should be introduced again. It's okay, I can start, I think. If you stop, I can start.
Yes, ma'am. Yes, ma'am. We are honored to have you, ma'am, and we would love to hear from you the clinical perspectives of embryo transfer. We can see the screen, madam.
So today I would be talking on embryo transfer. What are the clinical strategies for the success? So we know that over the years there has been increase in the pregnancy rates with ERT, and this is basically related to better control ovarian stimulation protocols, improvement in laboratory culture, as well as the environment, better assessment of embryos, as well as standardized embryo transfer techniques, and that's what we are going to discuss today. We know that embryo transfer is a rate-limiting step in IVF success because apart from the embryo quality and the endometrial receptivity, it is the embryo transfer procedure that determines the final outcome of an IVF cycle. It's seen that almost 30% of ART failures are due to the poor performance of embryo transfer, and probably we know that we can say that it is the least successful step in IVF. Because it is less sophisticated yet more vulnerable step of IVF process, its performance remains largely operator dependent, and despite major advances in the field, the process of embryo transfer remains the most unchanged one. The operator is very important in the success of ART, where we have the clinician in India, but abroad we also have the nurses who do the embryo transfer, and they are responsible basically for the insertion of the speculum and the embryo transfer catheter with the transfer of the embryos. We could also again have a doctor or a nurse who's responsible for the abdominal ultrasound for all embryo transfers which are done under ultrasound which are ultrasound guided. And the embryologist is basically the heart because it is his vision as well as his knowledge and his perfection which results in production of good quality embryos, and then the loading of the catheter is most important. Therefore, developing a standardized embryo transfer approach is expected to maintain the higher pregnancy rates as well as lower adverse effects. And we know that there could be different effects of a difficult embryo transfer on a pregnancy outcome. And basically, they could be related either to the use of stillets, change to another catheter, use of a tenaculum, and wherein you fail to enter the uterine cavity and you keep on trying, we at times we need to call for help. We have to freeze the embryo and transfer on some other day, and also use of cervical dilators. So all these can decrease the success rate of IVF. And if you look at this bar diagram, you can see that the pregnancy rate was highest when no additional maneuvers were used, whereas when outer sheath was used, that is when you're using the afterloading technique, the pregnancy rates were almost about 37%, which were not significantly different when no maneuvers were used. But with the use of stillet or tenaculum, you can see that the pregnancy rates decrease significantly from those cycles where no additional maneuvers were used. So what are the different steps? So one is we need to expose the cervix with a bivalve speculum. We have to clean it with normal saline. We have to remove the cervical mucus, ensuring that there's no bleeding which is induced when we are removing the mucus. There's no evidence of an effect of pregnancy rate for removal of cervical mucus prior to embryo transfer compared with no removal. That was the only one paper which I could find, which was published in 2010. But then you can see that ASRM also has recommended removal of the cervical mucus. Then the cervix is cleaned with flushing media, and then there is actually no need to use any antibiotics because it has shown not to increase the clinical pregnancy rate or the live birth rate. And then the embryologist loads the embryos into the embryo transfer catheter using the 3-drop procedure and gets it to the clinician for transferring the embryos. So if you look at the transfer technique, the loaded catheter, as you can see over here, is entering. So this is a preload technique. And once the outer catheter is at the internal os, the inner catheter is passed and we deposit the embryos about 1 to 1.5 centimeter below the fundus, which you can clearly see over here. This is the place where the embryos have been deposited. So the inner catheter basically is should be advanced in such a way that it does not touch the fundus, because if it touches the fundus, it's going to induce myometrial as well as endometrial contractions. Then again, if you look at the injection speed, basically there's very insufficient evidence to recommend any specific speed. There's fair evidence to recommend immediate withdrawal of the embryo transfer catheter after embryo expulsion, and the catheter is drawn back into the introducing cannula, and the two then are removed together. It is then flushed with the media under a stereo microscope to ensure that the embryos were released into the uterine cavity. So what are the different parameters that can affect the embryo transfer outcome? One is the anatomy, wherein we need to look at the uterine position, the uterocervical angle, presence or absence of cervical mucus, the uterine contractions, as well as microbiological factors in the cervix, as well as bacterial contamination of the catheter. Then when we talk about the catheter, we have to see whether it is soft or firm, what is the inner diameter, and also the shape of the tip of the catheter. Then the loading and the transfer media, wherein we have to look at the volume, both of the media as well as the A column, what we take, the viscosity of the media, as well as whether one has used any adherence compound or not. And technique is most important, wherein we know that ultrasound-guided embryo transfers are the best. The catheter tip location and position of embryo deposition in the uterus again is important. What is the injection mode? Whether the embryos are retained in the catheter? What was the ease of transfer? The presence or absence of blood in the catheter tip? The rest after embryo transfer? And most important is the experience of the physician. So coming first to the anatomy, the uterine position and the uterocervical angle is very important. And in the presence of pronounced anteversion, anteflexion, or retroversion, or an acute cervicouterine can result in acute cervicouterine angulation with a difficult embryo transfer. And therefore, proper evaluation of the uterine cavity as well as the uterocervical angulation is very important. And this can be by performing mock transfer by ultrasound and hysteroscopy if there has been a previous difficult cervical cannulation either at IUI or at a previous embryo transfer. So I think a passive bladder distension has a role in straightening the uterus and the abdominal ultrasound helps in navigating the embryo transfer catheter through the cervix into the uterine cavity, where the optimal site for deposition of the embryos can be chosen. And the uterine straightening by this by the passive bladder distension provides a smoother insertion through the internal os. So when we talk about getting rid of the cervical mucus, though it was controversial in the previous slide where I spoke, wherein one paper said that it's not necessary, where most of the other papers, as well as the ASRM, recommends removal of the mucus, which is important because it is a serious obstacle to a proper embryo replacement, because it can plug the tip of the embryo transfer catheter, causing difficulty in delivering the embryos inside the uterine cavity. Embryos can stick to the cervical mucus around the catheter and can be dragged outside during the withdrawal of the catheter. And if the mucus is pushed or injected higher in the uterine cavity, it may interfere with the implantation, and therefore removal of the cervical mucus at the time of embryo transfer is said to improve the clinical pregnancy rate as well as the live birth rate, and this has a grade B evidence. Myometrial contractions, again, and endometrial contractions are important because increase in the endometrial peristalsis and myometrial contractions. As you see in this, you can see these endometrial peristalsis. They are correlated negatively with the implantation, and it is a stimulation of the cervix and use of tenaculum that releases oxytocin and thus increasing the uterine contractility. And as you can clearly see over here, that the best pregnancy rates were seen when the uterine peristaltic wave was less than 2. And there are several papers which have said that having the uterine peristalsis waves of less than 3 before embryo transfer indicates a favorable pregnancy outcome, which is nicely illuminated in this bar diagram, wherein you can see that with increase in the peristalsis, there is decrease in the clinical pregnancy rates. So what are the precautions then we need to take to prevent these contractions? One is use of soft catheters to avoid trauma to the endocervix or endometrium. Avoid touching the uterine fundus as it is associated with initiation of uterine contractions. One has to go in for gentle manipulation to prevent the release of oxytocin, and therefore one must avoid holding the cervix by valsellum. And introduction of the speculum should be gentle to avoid unnecessary pushing of the cervix. And it has and many a times we administer a single dose of 10 milligrams of piroxicam about 1 to 2 hours before embryo transfer to quiescent the uterine musculature. One also needs to look at the presence or absence of any endometrial fluid which is there, because we know that it is associated with poor prognosis, and it could be due to cervical mucus that ascends into the endometrial cavity, fluid reflux from a hydrosalpinx, subclinical uterine infection, or also an abnormal endometrial development, and presence of persistent fluid accumulation. One should not do an embryo transfer, but freeze all the embryos and transfer them in a subsequent cycle. Coming to the use of prophylactic antibiotics for microbiological factors in the cervix or bacterial contamination of the catheter, and we all know that it is basically not necessary because it has shown not to improve the pregnancy rates after an embryo transfer, and therefore a routine prophylactic antibiotic before embryo transfer is usually not recommended. Then coming to the catheter, we know that we have two types of catheters which are available. One is the soft and the other is the firm or the rigid catheter. And in the soft catheter, we also have another subgroup, which is an echogenic catheter. So an ideal catheter has to be soft and flexible, avoiding any trauma to the cervix and endometrium, but malleable enough to find its way into the uterine cavity. It has to be non-embryotoxic, free of bacterial endotoxins, and must give full control in positioning the catheter tip in the uterine cavity, and it also must be clearly visible on ultrasound. And if you look at this meta-analysis which was published, we can see that the clinical pregnancy rate and the live birth rate are significantly higher with the use of soft catheter as against the rigid catheter, and therefore they are preferred as they are associated with significantly higher clinical pregnancy rate and live birth rate, and this has a grade A recommendation. Coming to loading of the catheter and transfer medium, which would also be discussed by Ashwini, but I would just like to say that normally we do the 3-drop procedures, and the embryos are basically separated from the preceding culture media by a small droplet of air. So you have the media, which is 1 microliter, air 1 microliter. The embryos are in 5 microliters of culture media, which is then separated by a culture media of 3 microliters by 3 microliters of air. And the final volume that is deposited into the cavity is basically only about 8 to 10 microliters. And there are several papers, and this recent paper in Human Reproduction Open has shown that small volumes that are put into the uterine cavity of 10 to 30 microliters are associated with higher pregnancy rates. Then coming to using media, which is enriched with hyaluronic acid, again, there are a lot of, or most of the results or evidence is controversial. Some say that there is no evidence that it can improve the clinical pregnancy rate. But this one paper from Fertility and Sterility has shown that there is an improved fertility outcome after ART, as you can see in this forest graph. Coming to the techniques which are most important, which is going to help us in increasing the pregnancy rates, is the ultrasound-guided embryo transfer, where we use a transabdominal ultrasound, and it was first done in 1985. And we know that there is a good evidence, and it's probably, we can say, a grade A recommendation that ultrasound-guided embryo transfer improves the pregnancy rates. So why does it happen so? So it confirms the position of the tip of the embryo transfer catheter within the uterine cavity and the site of embryo transfer, as you can see over here. It avoids contact with the fundus, avoiding endometrial indentation, and the air bubbles visualized on ultrasound, as you can see over here, indicates the position of the embryos that have been deposited, and a distended bladder alters the uterocervical angle and allows an easy transfer, requiring less frequent use of tenaculum or an obturator. And the Cochrane review also, which looked at 17 RCTs, has concluded that ultrasound-guided embryo transfer increases the ongoing clinical pregnancy rate over a clinical touch method. And this was statistically significant. And you can see that the forest graph also shows that it favors ultrasound-guided embryo transfer. Then, whether you see a jet phenomena or not is also important. When you see a jet, it is a free flow, and when you don't see, it's only the deposit which is visible. And here you can clearly see that when the embryos are pushed, you can see a jet over here. Yeah. So you can see that. So it has been seen that the pregnancy rates are significantly higher when the jet phenomena is seen as against when it is not seen. Then we also look at whether there is any influence on the pregnancy rates, whether the catheter is visualized or not during the procedure. So there are two things what we need to look at. One is the good or an excellent visualization during the whole embryo transfer procedure. And the second is problematic visualization, but tip identification is possible, or there is poor visualization. And you can see that the implantation as well as the clinical pregnancy rates are significantly higher when there's good or excellent visualization as against fair and poor. And this is also statistically significant, the p-value being 0.009 for implantation rates and 0.03 for the clinical pregnancy rates. Then whether the echo tip has any advantage? Yes, it definitely has, because it increases the visibility, it simplifies the procedure, and also there is decrease in the percentage of difficult transfers that has been seen, because you can clearly visualize the catheter all throughout its insertion into the uterine cavity. And this is because of the echo tip which is present at the tip of the catheter. Then coming to the position of the catheter tip is, again, it is very important. And there is a fair or a grade B evidence that embryo transfer catheter tip placement in the upper or middle uterine cavity, that is more than 1 centimeter from the fundus, improves the pregnancy rate. And there were also several papers which said that if it has been deposited less than 5 millimeters from the fundus, then there is a significant drop in the pregnancy rates. And the best location is anywhere between more than 10 millimeters to 20 millimeters, that is 1 to 2 centimeters. That is, this is in the upper and the lower part. And it really does not make a difference whether it is more than 1 centimeter or it is between 1.5 to 2 centimeters, because you can see that the pregnancy rates are almost similar and they're not statistically different. And there were several papers then which were published, and they looked at the transfer distance from the fundus as a parameter for the success of any embryo transfer procedure. And what they concluded that the implantation rate and the clinical pregnancy rate is significantly influenced by the transfer distance from the fundus. The guidance on optimal catheter tip location has been based on two-dimensional ultrasound imaging and a distance of more than 10 millimeters to less than 20 millimeters, as I've already told you, seems to be the best site for embryo transfer to achieve higher pregnancy rate, and this has a grade A evidence. Then they also looked at whether a 3D or 4D ultrasound increases the pregnancy rates, and most papers said that it really does not make a difference whether one is using a 2D or a 3D ultrasound. And then there was a paper which assessed whether a 2D ultrasound provides accurate assessment for catheter tip placement. And what they concluded was that the uterus naturally lies in different positions in each woman, as you can see over here, and the same is true regarding its anatomy, because one could have an arcuate uterus or one could have a different fundus. So you can see the different types of uterus which a patient can have. And then there were controversial conclusions drawn on it. Some said that two-dimensional view is good enough, and whereas some said that probably it might not give us an accurate view of the deposition of the catheter and where the embryos have been deposited. And when they compared the 2D versus 3D, you can clearly see over here that the 3D had a higher pregnancy rate as compared to 2D, which was used during embryo transfer. And these two papers concluded that there are several cases of suboptimal catheter tip on 3D, despite appeared optimal on 2D. So on 2D, they appear normal to be deposited in a proper place. But when you switch on to a 3D, you see that the catheter tip is in a suboptimal region. So they also said that two-dimensional assessment of the optimal mid-sagittal view and subsequently of the distance of the catheter tip to the fundus could really be elusive. So though we say that a transabdominal guided ultrasound is one of the best options, again, there's a lot of controversy whether we should use 2D or 3D, because most of the times what we are using is a 2D and not a 3D imaging when we are doing the embryo transfer. Then the interval between loading and discharging the embryo discharging the embryos again makes a difference. And if the interval is longer than 120 seconds between loading and discharging of the embryos, it is associated with significant decrease, as you can see over here, in both the implantation as well as the pregnancy rates. Again, we have to look at the speed of the embryo fluid injection. That again is done by a clinician. So a rapid injection can result in embryo trauma, and it can also lead to embryo placement issues and possibly promotes ectopic pregnancy. Though there is insufficient evidence to recommend any specific injection speed at the time of embryo transfer, which has a grade C evidence. But then let us I think I'll again come to that because I think the slides are later. So then when we look at the bed rest, basically what it does, it reduces anxiety, stress, as well as it gives psychological support. But we know that there is no evidence that prolonged or brief bed rest has shown to offer benefit over immediate ambulation, and there is good evidence not to recommend bed rest after embryo transfer, which has a grade A recommendation. So, on the contrary, if you see this paper, which was published in 2013 in Fertility Sterility, the rest group has shown to have lesser live birth rates, as well as increase in clinical miscarriage rates than that group which did not take any rest. But then later there was a paper which was again published in Fertility Study in 2022, where it not only looked at the rest, but it also looked at the rotation of the catheter, and they found that there's no difference in the clinical pregnancy rates, whether you take bed rest or you don't take bed rest. And when they looked at the rotation of the catheters, again, the ongoing pregnancy rate was 33%, and it was 23% with no rotation, but this did not reach any statistical significance. And they also looked at the timing of the catheter withdrawal. So this paper looked at the pregnancy rate at slow immediate versus 30 seconds wait, and you can see there was no difference in the pregnancy rate. Whereas this paper looked at the ongoing pregnancy rate and spontaneous abortion rate, where they looked at immediate as well as 60 seconds wait. And again, you can see that they found there was no difference in the ongoing pregnancy rate and spontaneous abortion rate. So basically, once you deposit the embryos, we need to keep a constant pressure on the on the syringe and then withdraw, so that the embryos are not sucked back into the catheter. So what are the other variables that could influence the embryo location? So one is the inclination as well as the viscosity of the fluid inside the uterus. Then second is the speed of injection. And it is said that if you inject it anywhere between 1 to 15 seconds, basically you can look at the air bubble, which is the position of the air bubble, and it is seen that it usually really does not move. It also said that the injection velocity also greatly influenced the trajectories of the embryo, the type and diameter of the syringe and the catheter, as I will show you in the next slide, as well as the loading of the catheter. So this was a paper, and there was another paper also in 2020, where they looked at the embryo separation from the air bubble and the effect of the injection speed. And this was basically done by donated arrested embryos in a laboratory model of the uterine cavity. And the injection speed was basically generated by the computer-controlled peristaltic pump. And they saw that a fast ejection of the transferred load resulted in morphological changes, and it could also trigger apoptotic processes as well as delay the embryo development. So if you look at these figures, so if it was slowly injected, and this was in medium injection, and this was a fast injection, and what they concluded was that fast injection resulted in higher incidence of embryo separation from the air bubble than the slower injection. So you can see this is the air bubble, whereas here is the air bubble, and you can see that the embryo separation was faster if it was injected faster. So this basically depends upon the acceleration velocity of the transfer fluid, and this will again depend upon the pressure applied to the plunger of the syringe, because we know that the diameter of the insulin syringe is about 10-fold greater than that of the catheter. Then higher the difference in the diameter between the catheter and the syringe, the higher pressure is then transferred. And therefore, reduced pressure regimes have been observed with use of smaller plunger diameter syringes for embryo transfer. So actually, they should have come there. So it also looks at the viscosity of the medium. And what they said that increasing the viscosity of the transfer medium can decrease the chance of embryo retention and displacement towards the catheter. And this forest graph clearly shows that adding hyaluronic acid is beneficial in increasing the pregnancy rate. And this was a Cochrane review, which was published in 2020. So we can see that there is a lot of controversy basically in the use of embryo glue or hyaluronic acid during transfer of the embryos. Then one must also look at the position of the air bubble after embryo transfer. So you would have transferred it about 1 centimeter or between 1 and 2 centimeters from the fundus. But then post-transfer, you should see where the bubble has migrated, because while the catheter tip movements are manually controlled, the air bubble movement cannot be controlled by us, because that will depend upon the viscosity of the culture media. It will also depend upon the endometrial peristalsis as well as the myometrial contractions. And this paper assessed the air bubble position at 1, 5, and 60 minutes post-transfer. And they said that it could migrate from about 8 millimeters to 14 millimeters, and the migration is maximum at 1 minute, followed by 5 minutes, and least at 60 minutes. And this was statistically significant. And the pregnancy rates also, they looked at the pregnancy rates at 60 minutes of migration. And if it was a fundal migration, there was not much decrease in the pregnancy rates as compared to the static, which was 55% and 45%. But if it was a cervical migration, that it reaches more down near the cervix, the pregnancy rate significantly decreased as compared to static or fundal migration. Then the other thing which the results will depend on is the duration of embryo transfer. And therefore, interval between the catheter loading and discharging of the embryos into the cavity is very, very important. And when the delay was more than 120 seconds, there was decrease in the pregnancy rates from 31 to 19%, and the implantation rates also reduced from 15.9% to 9.4%. And thus, the reducing the duration between loading of the catheters and depositing the embryos is very, very important. And this has a grade A evidence. And this duration can be reduced if the clinician and embryologist have experience using the catheter. Mock transfer is performed before the start of treatment. The distance between the incubator and the uterus is short, that is between the laboratory and the transfer room. The transfers are performed on calm patients, and if one uses an ecotip catheter under ultrasound guidance. Then after removal of the catheter, it is important for us to look for presence of blood or mucus at the catheter. And it was said that presence of mucus of and the catheter after transfer is not associated with lower clinical pregnancy rates and live birth rates. And we always said that presence of blood is associated with lower pregnancy rates. But this recent paper, which was published in 2017, which was a practice committee report from the ASRM, it said that there is insufficient evidence to conclusively state that blood on the catheter after embryo transfer does, it's very difficult to say whether it does or does not adversely affect the outcome. And this has a very low grade evidence, and that is grade C evidence. Coming to embryo retention, pressure change in the uterine cavity during embryo transfer can influence the distribution of the transferred fluid. There could be high or low catheter volume load, and the distance from the fundus as well as the uterine anatomy, especially in the presence of narrow cavity. All these can result in embryo retention in the catheter. And you can see that when there is retention of the embryos in the catheter, there is significant reduction in the pregnancy rates. And therefore, we need to minimize the retention of the embryos. And that is the job of the clinician. And what are the steps what we need to take is to avoid blood at the tip of the inner embryo transfer catheter, remove mucus from the external os and cervical canal before embryo transfer, keep the volume of embryo transfer media less than 10 microliters, maintain adequate pressure on the syringe after embryo transfer, that is on the plunger, and withdraw the catheter very slowly after embryo transfer. Retain embryos in the transfer catheter and immediate retransfer do not really affect the implantation, the clinical pregnancy rate, as well as abortion rate, and this has a grade B evidence. Difficult embryo transfers may be due to presence of anatomical distortion of the cervix due to a previous surgery or fibroids or due to congenital anomalies, pronounced uterine flexion, scarring in the lower uterine segment, as well as distorted endometrial cavity. And in case of difficult embryo transfers, as one is assessing further course of action, it is best to temporarily return the embryos to the incubator. And once the outer catheter is placed at the internal os, you reload the inner catheter and then transfer the embryos. Like you can see, this is such a difficult transfer because despite the bladder was full, we really found it difficult for the outer catheter to reach the internal os, as you can see over here. And we could not visualize the cervix as well as the uterus in one single line. And we could not even see the inner catheter being passed, and we could only see the deposition of the embryo in the uterine cavity. So the quality of embryo transfer is very important, and we can divide it into four. One is easy. The second is where outer sheath is necessary to induce the soft catheter. The third is quality of probing of the cervix with the stillet and tenaculum use or blood at the tip catheter. And you can see that the clinical pregnancy rate and live birth rate is the best when it is a easy embryo transfer with a soft catheter. And the second is when you're using when it is the intermediate type of transfers. And this resulted in almost 1.7 times higher pregnancy rates. So you can see with difficult embryo transfers and prolonged duration, as you can see over here, the pregnancy rate significantly reduce. And this is because the embryos are exposed to almost a 10-degree temperature decrease within the first 20 seconds of being loaded into the tip of the embryo transfer catheter. And this drop in temperature could affect the embryo viability as well as the health of the embryos. And therefore, in any patient where you're suspecting that it could be a difficult transfer, it is best to use an afterload technique rather than a preload technique. The other most important factor is the experience of the physician, and you can see that each physician has a different pregnancy rate. And therefore, this human factor can be reduced by doing a trial or a mock transfer. And there were several other papers, and the last paper, the recent one I could find was in RBM Online in 2022. And you can see that there is a clinically significant increase in the pregnancy rates when the physician is good at performing an embryo transfer as compared to those who are not competent enough in performing the embryo transfer. So then what are the remedies for difficult embryo transfer? As I said, mock transfer, use of a stiffer and a more rigid catheter system, gently maneuvering the vaginal speculum, partially full bladder, use of ultrasound guidance to facilitate embryo transfer, moderate cervical traction and straightening of the uterus, use of malleable obturator followed by inner catheter with the embryos, use of coaxial or ecotip catheter strips, use of ultrasound guidance to facilitate the embryo transfer. And in very difficult cases, actually I've never done in my life any transmyometrial embryo transfers, or one could also do a transtubal embryo transfer, which we call as ZIFT. And as I said, afterload procedure is the best, and it significantly reduces the difficult transfer rates and may also reduce the embryo exposure to potentially unsafe condition. But if all remedies to overcome difficult transfers fail, then one needs to freeze all the embryos. One also has to look at the KPIs, which are very, very important, and where we need to look at the clinical pregnancy rate and the multiple pregnancy rate, which are calculated every 3 months or per 50 cycles, whichever comes first. And for this, we have to have a critical analysis and data reporting by all persons which are involved in embryo transfers in a systemic and multidisciplinary manner. They should document the equipment used, the duration of the procedure, the degree of difficulty, catheter loading details, as well as the embryo transfer technique. So I will end with the following take-home messages. So the key elements for a successful embryo transfer are an easy, atraumatic, and technically precise transfer without blood or mucus. And for this, one has to have a mock or a trial transfer. use an ultrasound guidance, and also use soft catheters. Proper placement again is important, wherein you need to inject the embryo slowly 1.5 centimeter from the fundus as confirmed by ultrasound. Minimize the embryo stress by minimizing the transfer time, controlling the temperature and pH. Negotiate a difficult stenotic cervix by pre-cycle dilatation using malleable stillet or ultrasound guidance, and optimize implantation and minimize contractions by doing a day 5 transfer. FET cycles if you have high estrogen levels, avoiding trauma to the cervix or fundus, and using piroxicam about 10 milligrams 2 hours before the embryo transfer. And thank you all for a patient hearing.
Thank you so much, Madhuri ma'am. I mean, even if I or anybody else read 6 textbooks today, ma'am, we would not have gathered so much information about embryo transfer. And I mean it, madam. This
No,
is
no.
this is a very concise, compact encyclopedia of knowledge. And my wish to every postgraduate who is doing ART or anybody who is practicing to please listen to madam's lecture. Madam, I will listen to it once again in a silent room so that I can grasp every study you have quoted. It was truly delightful, ma'am. Thank you, ma'am, and hats off to you, madam. There can be no other Madhuri Patil in India, at least.
Nothing like that. There are many more.
Madam,
So can we take the questions now or after both?
yes, ma'am. The platform is open for questions. The dignitaries who are here, and then I will introduce Secretary General, ma'am, Dr. Asha Bakshi. Ma'am, I wanted to ask you a question about piroxicam. You mentioned one oral tablet before 30 minutes or 1 hour before the procedure.
1 to
Uh,
2 hours before the procedure.
1 to 2. Ma'am, would you use any other NSAID besides piroxicam or any
I
specific
normally use
reason?
piroxicam. There are many who are using atosiban, but I personally do not have any experience with atosiban.
And ma'am, what about this? You in none of your slides was there any mention of MIP, the maximum implantation potential point, which is
Huh.
being described in many books as the point about 1 to 1.5 centimeter below the fundus, which many people say it's the best point to transfer. But you
Yeah.
have categorically mentioned that embryos move.
Yeah. There are studies that they show that embryos move, but basically what we introduce is, I did say, because I quoted so many studies also, because I didn't want to make it long, I didn't show the conclusion of each study. So, but I mentioned the best position is anyway 1 centimeter to 2 centimeters below the fundus.
Uh,
All the most recent papers suggest that.
Madam, sometimes the embryos after transfer, like after moving from the fundus, when we put up rope transfers, they seem to move towards one of the two cornu.
That
So,
is, if your injection pressure is more, then they would move more towards the cornu. So you have to keep a constant pressure. It has not to be very high also, and it has not to be low, because it has been said that with a little higher pressure, they move towards the cornu and into the tubes also. But if you keep a proper pressure, then and you deposit them, then their movement even inside the uterus is much less. And for this, it's also very important to see that there's no endometrial peristalsis, or there is also the uterine myometrium is also quiescent. So it is only in the presence of these waves, because we know that in the follicular phase, basically the endometrial contractions or the peristalsis is cervicofundal, and it is fundocervical. But then post progesterone, it becomes cervicofundal. And this cervicofundal peristalsis prevent the expulsion of the embryos outside the cervical cavity. So I think we also need to look at, and therefore our progesterone levels also should be adequate when we are doing the embryo transfer.
ma'am, what do you
Because
think
this
is
is
an
going to
adequate?
result in quiescent of the uterus and is going to prevent fundocervical waves developing.
Madam, what do you think is an adequate progesterone level, and should it be tested before doing a transfer?
Yeah, so it basically depends upon what drug you're using. So if you're using a vaginal progesterone, the level should be a minimum of 20 nanograms per ml. But if you're using injectable progesterone, it has to be 35 to 40 nanograms. If you're using dydrogesterone, basically it cannot be measured in the blood, and therefore the results, cannot be assessed and should not be assessed only if you're using the dydrogesterone. So for vaginal, it has to be 20. The threshold is 20, whereas for an intramuscular, it is 35 to 40 nanograms.
Madam,
So,
what is your personal opinion about an embryo glue?
so in my experience, I've really not found it to be of much use in increasing pregnancy rates, but I do use it in those patients who have had several implantation failures. So in these patients, we do use them. But otherwise, in my experience, we did quite a bigger studies, but we did not find that it really improved the pregnancy rates. But initial studies also showed that it didn't increase, but the recent studies have shown that it increases the viscosity of the media, and therefore it prevents the dislocation of the embryo from wherever it is deposited down into the lower part of the uterus or the cervix.
Thank you, ma'am. Somebody else was asking a question, I think. Okay, ma'am. Thank you so much, ma'am, for those wonderful inputs. I'm sure there are so many other questions which you all want to ask. So if there are any other queries, please put them in the chat box. I will WhatsApp them to ma'am and we will wait for her reply. So I think after this enlightening talk, we have a short break where we welcome Dr. Asha Bakshi, ma'am. So I would request our team to please welcome, ma'am, Secretary General ISAR. It is because of her and Dr. Amit sir that this program has seen the light of the day. And Madam is a revered figure in Madhya Pradesh and all over India. She is leading ISAR from the front. And at present, Madam is Director of Asha Bakshi Fertility Center at Motherhood Hospital, Indore. Madam has been also the Vice President of FOXY in 2022. She has held various posts in ISAR. She is a very active member of RCOG West Zone. She is the founder chairperson of MP chapter of IAGE as well as MP chapter of ISAR. She is a great endoscopic surgeon as well. She is the chairperson of FOXY Infertility Committee 2017 to 19 and as well as very active in ICOG. Madam has seen the Indore Obs Gynae Society grow into its glorious form today under her leadership. She is the highest and the greatest figure in Indore Obs Gynae Society at present. She is in the advisory committee of PCPNDT Indore. She has, to her credit, the first ICSI, TESA ICSI, and Micro TESA ICSI babies of MP, recipient of Dr. Kumut Tamaskar Award, and as well as Padma Shri Dr. S.K. Mukherjee Award and Dainik Bhaskar Excellence Award. Madam has, to her credit, several great conferences held in MP like the Star Endogyne, ICC On, ICC Con, ISAR 2016, ISAR 23, and the organizing secretary of IFFS 2016. She also, under her chairpersonship, did the AICOG 2022 at Indore, which was widely appreciated. Madam, we would love to have blessings from you.
Thank you, Monica, for such an elaborate introduction. It's really nice to hear you, and you are really a webinar queen, I must say, doing so well. So, first of all, I would like to thank Dr. Amit Patki that under his leadership, ISAR is really doing great work, and really honored to see Dr. Madhuri Patil, who is the Vice President elect, and who is the Vice President, and she's really knowledgeable. That is most important, that any small thing you ask and she has the answer for it. So what I said that today we did detailed micro learning of embryo transfer from her. And then I would like to welcome Dr. Archana Base, Dr. Meenu Agrawal, Dr. Mala Arora, Dr. Keshav Malhotra, who have honored us by being on this platform. And I would also like to any program cannot be really successful unless there are good co-conveners. And we have Garima, Manisha, Neelam, Ankita, Payal, and Purva, who are working very hard so that this program gets successful. And again, the chairpersons. I'm very honored that we have President IAG, Dr. Kalyan Varmari today, Manjul Nath from Bangalore, and today one speaker we have already heard, and I'm really mesmerized. And now again we'll have another star speaker, and that is Ashwini Kale. She's embryologist. So from embryologist perspective, we'll learn everything about embryo transfer. So a warm welcome, Dr. Ashwini. And I would also like to welcome our friend Dr. Neelam Bhasin, Dr. Prasad Lele, and Dr. Preeti Vyas from Mumbai. Hi, Preeti, I can see you there. So, hi. And the panel discussion on embryo transfer will be done by the two captains, and that is Monica and Randhir, and they are going to really raise important points. And they will be very well answered by the galaxy of speakers today. That is Ananta, Kanika, Mahima, Mugda, Parzan, Rachna, Riddhi, Rinoy, Shilpa, Surbhi, Vanisha, and Yukti. So, and this discussion will be so great, and further it will be enhanced. There will be a hue to it, and that will be given by Dr. Madhuri Shimote, Dr. Chaitanya Ganpule, and Dr. Prerna Shinde. So my best wishes, and still I can see it is going on very well. And I take this opportunity to please support me for the post of Vice President ISAR, second Vice President ISAR. And I have been with ISAR since almost more than 23 years, and have been in managing committee since 2012, and have done all the posts, whatever posts are there, I've finished all the posts, and currently I'm Secretary General ISAR, and I look forward to your wishes and your blessings. Thank you so much, and a warm welcome, Dr. Ashwini.
All the best, ma'am. Thank you so much.
Thank you. Thank you.
Best
Thank you.
wishes, ma'am. All our best wishes are with you, madam.
Thank you. Thank you so much.
May you have a resounding victory, ma'am.
I hope.
And now we have the pleasurable duty of welcoming our special guest. Madam has joined, Dr. Meenu Agrawal. Meenu, madam, are you there? I saw, madam.
Yes, hello.
Meenu, madam.
Hello, Monica.
Hi, Meenu, ma'am. So
I'm in the car, so maybe it's very dark, but yes,
Hi,
I am
Meenu.
there.
No, ma'am, but you are,
Hi, Meenu.
and you are lighting up
You're
the
Sanjay
car.
Agrawal.
Hello. Hello.
So we welcome our Vice President of Foxy West Zone 2026, Dr. Meenu Agrawal, who is also the special guest for the evening. And madam, I described special guest as the people who hold special place in our heart. So ma'am, we welcome you to the program. She is incoming VP Foxy, with a very good margin. She is also an avid academician, endoscopist, course director of the international training courses at UAE. Madam has headed the imaging committee of Foxy, so we know her as a keen, imaging specialist. Many publications in international journals, authored 4 books as first author, and of course, European board certified minimal invasive reproductive surgery surgeon. Welcome, Meenu ma'am. Love to have some blessings from you, ma'am.
Yes. Sure, sure. Thank you. Thank you, Dr. Monica. Very nicely, I heard almost full lecture of Dr. Madhuri Patil. Amazing lecture, A to Z. She is like you said very rightly, encyclopedia of IVF and the knowledge and the publications that she referred to. So very high quality program that both you and Dr. Randhir have organized. And thank you, Dr. Asha Bakshi. Always, I get an opportunity to spend more time with her whenever we meet in the conferences. So it's always nice. And your entire team, wish you all the best. And to keep 3 lectures only on embryo transfer with the panel, it is really amazing. So you have really found very, very good speakers. And the way you have distributed the embryo transfer from the embryologists to the clinicians and the panel, it's really nice. I'm sure the next 2 lectures will go very well. Ashwini, as an embryologist and even as a clinician, excellent choice of speakers that you have. So wish you all the best and wish you all the best in all your endeavors. You, Dr. Randhir, and Dr. Yeah, all of you. Thank you very much. Thank
Thank
you.
thank you, ma'am, for joining us.
Mhm.
We
And
value,
Dr. Asha Bakshi. Yes. Yeah.
we value your words a lot, madam. Thank you.
Thank
Please
you.
stay with us
Thank you.
if possible, ma'am. And
Sure, sure.
I think Ashwini is waiting. She has been preparing this lecture with great enthusiasm, studying day and night for it. Ashwini, the floor is all yours. But before we start, making you speak, we will have introductions of the people who are going to chair your session, and the chairpersons are very excited to welcome you. So, session number 2 goes to Payal Raghuvanshi. Payal, please start.
Thank you, ma'am. So our next interesting session would be on the topic embryo transfer from embryological perspective. So for this, I would like to thank everyone to give me the privilege to introduce our chairpersons for this session. So our first chairperson is Dr. Nirmal Bhasin, ma'am. She is director and clinical embryologist, Janani Fertility Center. She was secretary IMA Chandigarh and was immediate past chairperson ISAR Chandigarh. She has been a pioneer in third party reproduction and surrogacy in Chandigarh. She is a member of ISAR, IFS, ACE, IMA, and she has various awards to her credit. She has been awarded the Dronacharya Award as well. I welcome you, ma'am. Our second chairperson for the session is Sir Brig Prasad Ravindra Lele, sir. He's presently brigadier and has been has held important past positions as consultant professor and head HOD as dean and commandment MH Jalandhar. He was professor and HOD obstetrics OBGY's department Ashwini Mumbai, and has been and also has shared the same post in CHEC Kolkata. Sir has been awarded as Lieutenant General K Master Memorial Silver Medal Army Cadre Commendation Award. He has various publications in national and international journals and has contributed various chapters in books. And he's also an editorial referee for MJAFI, Jogi, JHRS, and TJGOS. I welcome you, sir. Our third chairperson for the session is Dr. Preeti S. Vyas, ma'am. She is a consultant obstetric gynec and lab surgeon in various hospitals in Mumbai, Surya Mother and Child Care, Max Nanavati Hospital, Bharti Arogya Nidhi Hospital. She is an active member of MOGS, managing committee member and patron member of Maharashtra OBGY Society. She is a youth cell mentor and convener for outreach programs, a peer reviewer in Jogi and Foxy Journal. She's a national coordinator and trainer for Youth Mela Foxy and has conducted more than 200 Youth Mela All India. She's the organizing secretary of Foxy, MOGS Youth Summit and YouthCon, and a past treasurer of ISOPAP conference. She has various awards to her credit. The best mention award is Dr. Durusha Best Commitment Award, and she has been awarded this in 2013-14 from 2023 to 25, and has also been awarded Mrs. Shelja Pandit and Narayan Pandit Award for the work done towards women empowerment in 2015. I welcome you, ma'am. Now, I would request our chairpersons to introduce our speaker, Dr. Ashwini Kale. She's my senior also from BJ. She has taught me, and I am very excited to listen to her. So the mic goes to the chairpersons.
Thank you. Thank you so much, Dr. Payal. Yeah. Should I take the pleasure of introducing Dr. Ashwini?
Yes, ma'am. Sure.
Yes. Yeah. So Dr. Ashwini is a dear friend, and of course, all of us know her as the pillar of strength for Dr. Sunita Tandurkar, Madam, the Foxy president. But she's right now also the joint secretary for Foxy, and a lot of credit goes to Ashwini's silent work, that so many programs have really come out towards the fag end of the year this year, Foxy. She's done a fellowship in clinical embryology from Singapore and is a director and the chief embryologist of Asha IVF Center, Pune, with more than a decade of experience in the field of embryology and has trained many embryologists till date. She's an elected MCM member of ISAR. She's also the treasurer of Maharashtra chapter of ISAR. In the past, she's the MCM of Maharashtra chapter ISAR in the past, a chairperson of the AMOGS committee, a past secretary of the Pune OBGYN Society, as well as the zonal coordinator for AMOGS in 2018 to 20, has been awarded multiple awards, including the Foxy Sun IAEC Traveling Fellowship in 2021, the Shanti Yadav Award of Foxy on Infertility in 2022, Dr. Shirish Daftari Award by the Pune OBGYN Society, and the Dr. Smita Jog Award, again by the Pune OBGYN Society. She's also received the prestigious Dr. Sanjeev Khod Award for original research work in infertility and the ISAR Embryology Excellence Award by ISAR in the year 2023. So we really look forward and we're really keen and eager to listen to you, Ashwini. Over to you. The mic goes to you.
Thank you so much, Preeti Madam, for the lovely words. I'm really flattered. And thank you, Nirmal Madam and Bindu Madam, for chairing this session. I'm really glad that all of you are there. I think today Monica Madam gave me the most difficult job of speaking after Madhuri Patil Madam. I mean, there's nothing that anybody could speak after an encyclopedia is open and read by all. So I think this is going to be really tough for me today. Nice to see you, Payal. I think I am seeing you after a decade today. And heartiest congratulations, Monica Madam, because you are the reason that I have been seeing these perfection series, I think, over the past 2 or 3 years now, I guess. So a big congratulations to your hard work. And I think now Randhir sir has also joined. So wishing you all the very best for the elections. All the best to you, Asha Bakshi Madam, as well. I think today's topic is pretty difficult and a routine one also, you may say, the embryological aspects of embryo transfer. As we all know that this is that one last critical step where everybody is waiting to get the best of results. It is both the clinician, the embryologist, and also the patient. Because no matter how good you do the ovum pickup or how many good embryos you have, ultimately when this one step goes really well, this is what gives you the good result. This is the final and the most crucial step, and the basic goal of any ART treatment at the end of the day is to select a high quality embryo that you transfer to the uterus, and it ultimately results in the birth of a healthy child, because these days we look at a live birth rate rather than the clinical pregnancy rate. A single embryo transfer definitely reduces the incidence of multiple pregnancies after IVF. That is why we have to select that one embryo with utmost precision, because this is what is going to ultimately give you the pregnancy. So we all probably select that one embryo because it is still a probability that this is going to land up in a pregnancy. So now what are the various factors which actually affect the embryo transfer from the embryological point of view? It is the implantation capacity of the embryo. To increase this, we may opt for PGT, we may opt for hatching, we may opt for glue, but none of the techniques to date are endorsed key as to which is that one best technique which will give you one live birth. Then, as far as the clinician is concerned, it is the endometrial receptivity, which may be checked by ERA, Doppler, or the various preparation protocols that one may use to get the best of the endometrium. And finally, the coffin in the nail is your ET technique. Now, coming to hatching, before uterine implantation may occur, this generally occurs naturally by an enlarged blastocyst which may hatch outside the zona. So, if the thickness is more than 16 mm, it is hard to implant. So, we generally do this technique probably in a frozen embryo transfer cycle, or when you feel that the zona is too thick or too hardened. The proteolytic sublysis of the zona by the embryo or the endometrial lining, and the hydrostatic pressure which is created by the blastocell fluid inside which is developing, these are the processes which basically allow the zona to rupture naturally and the blastocyst escapes. Assisted hatching was proposed to foster the spontaneous hatching and to improve the embryo implantation. So there are various methods by which we do it. You can either do it physically, chemically, or the most frequently used or the commonly famous technique is the laser assisted hatching, which is a non-contact mode, which you use an infrared diode laser beam. Because of the short exposure time and accurate positioning, it's a simple operation. Though it looks pretty simple, it requires a lot of precision. It has an indirect contact with the embryo. You have to see that you don't damage it. You just have to hatch the zona. and it is an equally effective procedure. Now, do we do this hatching in all the patients? Probably the answer would be no, and that is why the in thing today or in these many years is doing a tailor-made procedure for all the patients. So if you feel that this patient would require a hatching because she had a previous cycle of failed frozen embryo transfer, you may try hatching. So thinning and drilling laser assisted hatching in thawed embryo transfer. This is a randomized controlled study where they studied the zona pellucida which could be damaged due to hardening. The laser assisted hatching can increase the pregnancy rate is what they found out. It compared the thinning and drilling of the zona just before the FET. So what they did is patients were randomly allocated into two groups for LAH using thinning or drilling on day 2 after thawing, and 25% of the zona circumference and 50% of the thickness was removed in the thinning group, and a hole of 40 micrometer diameter was made in the drilling group. So there are two different things that they did. One is the thinning and one is the drilling. So they found that in almost 171 patients, sorry, one sec. Yes. Are you able to see my screen?
Yes, Ashwini. Yes, we
Yeah,
can see the
I'm
screen.
I don't know. I'm not able to see it suddenly. One second.
We are able to see it.
No, you go to this thing now. There is one meeting and there's one Ashwini Kale. So you go tap on that Ashwini Kale. So you'll be able to see your own screen.
No, now I'm able to see myself only. One sec, I'll again reshare it. I don't know what happened. Yeah. Yes. So basically, the thinning had a similar beta HCG positive rate, implantation rate, and the clinical pregnancy rate or the miscarriage rate. So there was no significant difference in pregnancy outcome in these subgroups, which are defined based on an older age group, that is age more than 35 years, or a zona pellucida thickness greater than or less than 17 micrometers, according to the LH method. So this study basically demonstrated that partial thinning or drilling resulted in similar outcomes in implantation and pregnancy rate using thawed embryos, irrespective of the women's age or the zona thickness. Then the second thing that we do is comparison of these pregnancy outcomes using a time-lapse monitoring system for embryo incubation versus a conventional incubator in vitro fertilization. So this is a age stratification analysis because now we know that we have always done a morphological analysis of the embryos. Now we do a morphokinetic analysis and now we have time-lapse to our aid. And to top it, we even have an AI guided with using time-lapse. So does this really help in increasing the pregnancy rate? So the aim of the study was basically to compare the pregnancy outcome of IVF with embryo transfer, with embryos cultured in a time-lapse system and those in a conventional incubator. So these were the medical records of 250 fertilized embryos from 141 different patients who underwent infertility treatment in a span of 2 years. The time-lapse application improved the live birth rate, implantation rate, and the clinical pregnancy rate, particularly in the advanced age group in this study, while the other reproductive outcomes were comparable. Though we still need a large randomized clinical study to further explore the ramification of these findings to actually say that time lapse definitely helps in increasing the live birth rate. Embryo selection still remains a critical determinant when it comes to conventional morphological assessment because it still lacks predictive precision and it is prone to subjectivity because what I may find is a good morphological embryo may not be the same to some other embryologist. So two advanced technologies, one is the time-lapse imaging and the PGT, they have emerged to enhance this embryo viability assessment, yet the comparative effectiveness remains uncertain. So this was a very good study of 20 eligible studies which was analyzed. The time-lapse studies reported improved morphological assessment because it is still non-invasive. There is real-time observation with pregnancy rates ranging between 27 to 68% and the live birth rates were 45%. As against PGT, which is an invasive procedure, there were definitely superior outcomes when it came to implantation, which was almost 76% as compared to 27%. And the live birth rates were almost 78%, which were just 45% in time lapse. So that is also almost double, especially among patients with recurrent pregnancy loss or advanced maternal age. So this definitely reduces their time to pregnancy. We all know that PGT still carries the risk of embryo damage because it is an invasive procedure. There is an associated or an over and above cost involved with it, and it definitely requires a longer processing time because the results may take around 3 weeks to come. As we all know, that time lapse still offers a safer and a cost-effective option for embryo selection because it is non-invasive. There is minimal risk to embryo integrity. The TLI's integration with software such as IDA scores, which is nothing but AI integration, it further enhances the diagnostic capability. Nonetheless, in specific clinical scenarios like recurrent miscarriages or when you have known genetic disorders, PGT is still indispensable. They ultimately concluded that both time-lapse and PGT offered significant advantages in embryo assessment. While time-lapse is favorable for routine, non-invasive monitoring, PGT is still critical for genetic insights. Coming to prediction of live births and selecting embryos based on morphokinetic parameters. So this is a very good study which involved a total of 1060 embryos, out of which 585 were euploid and 475 aneuploid after PGTA was done, with a good morphology from 329 patients in a period of almost 5 years. So all these embryos were cultured in a time-lapse incubator, and the trophoectoderm biopsy was done for PGTA, which was performed either on day 5 or day 6 of the culture. And during this period, they did frozen embryo transfer for 225 of them, of which one euploid embryo was performed. Based on the treatment outcome, these embryos were divided into two groups. One is an euploid embryo, which gave rise to pregnancy, and another is an euploid embryo, but which gave rise to a missed abortion or an pregnancy which did not show any fetal heart rate. Based on this statistical analysis of the embryos without implantation and the embryos with live birth rate, it clearly shows that there is a morphokinetic parameter, which is T5, that is time of division into 5 cells, and the time to blastulation are significantly different. So the lesser the time they take, the better the outcomes are seen. So this shows that morphokinetic parameters of T5, that is time of division into 5 cells, and time to blastulation are predictive indicators for selecting an embryo with high developmental potential and a high probability of achieving a healthy child, that is a live birth rate. Now coming to day 3 versus day 5 transfer, we all know that we have moved on to day 5 transfers, but still there are no robust clinical studies or no Cochrane data which says that day 5 embryo transfer is the call of the day. So this was a very good study which was published in 2022. They had 266 patients, all undergone ICSI, with 221 patients having undergone day 3 embryo transfer and 45 had undergone day 5 embryo transfers. So patients who had more than 5 good quality embryos on day 3 were chosen to prolong the culture to day 5. So transferring day 3 provides the same benefits as would a day 5 embryo transfer to patient. However, more embryos are required to achieve these comparable results, because we all know that on day 3 we transfer at least 3 embryos, and on day 5 it could be one single embryo transfer or 2 embryos at least. Now, what are the comparative outcome of day 3 versus day 5 frozen thaw embryo cycle? This was a retrospective clinical study which aimed to compare the clinical outcome of day 3 versus day 5 transfer. So this is also a challenge in these FET era, that whether to transfer on day 3 or whether to transfer on day 5. And the third, another confusion is whether to thaw these embryos on day 3, take them till day 5 and then transfer them on day 5. So retrospective analysis was conducted on almost 6,445 patients who underwent this frozen thawed embryo transfer. And they found that the pregnancy rates were significantly higher in the blastocyst transfer group. The cleavage stage group had a higher number of embryo transfers, probably due to lower implantation potential per embryo. But the patients with diminished ovarian reserve had lower embryo freezing rates because they could not reach to the time of getting the embryos frozen on day 5. Blastocyst stage transfers show better synchronization with endometrial receptivity, but always carry a risk of embryo attrition. They concluded that a blastocyst transfer is associated with a higher pregnancy rate and it should be preferred whenever viable embryos are available. However, cleavage stitch remains an alternative for patients who have got a poor embryo development. This could be tried in patients who may not reach till day 5, who may not have enough number of embryos to wait till day 5, or probably who had a previous day 5 embryo transfer failure. An individualized approach or a tailor-made approach is what we do these days for optimizing the ART outcome, because there are still no robust results on whether you would do a day 3 or a day 5 transfer. Now doing single versus 2 embryo transfer. That is, we are moving towards the day of doing a single embryo transfer on day 5. Now, what is the call of the day? Whether it is a single embryo or 2 embryo transfers or a double embryo transfer. So comparison of benefit and risk of a single embryo transfer versus double embryo transfer, a systematic review and meta-analysis from 2022. So the pre-specified primary outcome were live birth rate and multiple pregnancy rate. So they studied 85 studies, of which 14 were randomized controlled trials and 71 observational studies were eligible for this. And they found out that compared with a double embryo transfer, a single embryo transfer decreased the probability of a live birth rate and lowered the rate of multiple pregnancy. There was no significant difference in live birth rate for a single good quality versus two embryos of mixed quality. So, putting in even two poor quality embryos would still give that patient a chance to become pregnant. Nor was there any difference in the multiple pregnancy rate when you put in a single poor quality embryo versus two poor quality embryos. Moreover, the women who conceived through a single embryo transfer, they were associated with lower risk of poor outcomes like cesarean section, APH, preterm birth, low birth weight, Apgar less than 7 or NICU admissions than those which happened due to double embryo transfer or two embryo transfers. In women who are aged less than 40 years or in those having a good quality embryo, a single embryo transfer should be incorporated into clinical practice. Whenever there is absence of one single good quality embryo, two embryos could be transferred on day 5. However, for elderly women that is more than 40 years, the current evidence is still not enough to recommend an appropriate number of embryo transfer because in this particular age group, you are looking at getting a positive result also and at the same time reducing the risk which would happen because of twinning and the other complications of prematurity and preterm in the babies. Now, coming to culture media. Now, which would be the best culture media? Is it the sequential media? Is it the single step media? So, it is still unclear how this composition of media affects the embryo quality and the IVF or the ICSI success rates, and which, if any, culture media leads to that highest IVF ICSI rates. We all know that Montague performed in 2013 a systematic review that included 22 studies of 20 different culture media from 11 commercial companies, but we still are unable to find a superior culture media from the pool data. It is still unlikely to find that perfect medium composition exists or that only one formulation which is suitable for doing the embryo transfer. So probably if we get that one important culture media which has all the perfect ingredients to get the positive pregnancy rate, so then probably our pregnancy rates would jump in from 40, 60 to 100%. Now, what is the role of embryo glue in implantation? There was a time when we spoke a lot about embryo glue, which showed there were quite a few studies which actually showed positive results when you used embryo glue, but few studies which said that it does not make any difference in the live birth rate. So it still has to be individualized as per your center to optimize the results. Now, coming to immediate versus a postponed FET cycle after IVF ICSI. This is a very good systematic review and a meta-analysis where they waited for 1 month for the patient to for the patient's ovarian milieu to come back to normal and then did an embryo transfer. So we all know that in Europe, the number of embryo transfer FET is steadily increasing. It is increasing all over the world. Now it accounts for more than 19,000 cycles per year. It is a standard clinical practice to postpone FET for at least one menstrual cycle following a failed fresh transfer or a freeze-all cycle. The purpose is to basically minimize the possible residual negative effect that an ovarian stimulation would leave on the ovulatory cycle and the receptivity of the endometrium. The results of this review indicate a slightly higher live birth rate and a clinical pregnancy rate in immediate versus a postponed FET. They found that even 1 month postponing declined the results or decreased the results. Thus, the standard clinical practice of postponing FET for at least one menstrual cycle following a failed fresh or a freeze-all cycle may not be the best clinical practice. However, as only retrospective cohort studies were assessed, the presence of this selection bias is apparent and the quality of evidence is also low. Randomized control trials, including data on cancellation rate and the reasons for cancellation, are highly needed to provide high-grade evidence regarding clinical practice and patient counseling. Now, coming to obstetric and perinatal outcomes after embryos, which are cultured in one step versus sequential culture media. So, does it make any difference? That is, warmed single blastocyst transfer cycles. So, does the type of culture media influence obstetric and perinatal outcomes after you do a vitrified worm or an FET cycle for a single blastocyst transfer? So, this is a retrospective cohort study involving singletons after vitrified worm single blastocyst embryo transfer using embryo culture in either iron continuous single culture media or the vitrolife medium between 2013 to 2020. So they found that there is current evidence which suggests that the embryo culture media does not affect any obstetric outcome or the birth outcome when they have compared iron to vitrolife media for a single blastocyst transfer. So can time-lapse culture combined with AI, as we all know that we are moving towards AI, improve ongoing pregnancy rate in fresh embryo transfer of a single cleavage stage embryo? So this is a study from China. Don't know how much true it is, but it is very interesting to know that if we integrate this AI into a time-lapse culture for embryo screening, the pregnancy rate in ART have significantly improved, is what their study proved. However, the clinical pregnancy rate in fresh cycle remain dependent on the number and type of embryos transferred. The selection of embryo with the highest implantation potential is critical for embryologists and influences the transfer strategies in all our fertility centers. The superiority of OAI over traditional morphological scoring for ranking these cleavage stage embryos based on their implantation potential still remains controversial. So this is a very good area to study, that whether these AI based assessment versus our routine morphological or morphokinetic assessment would be superior. I think if we get a huge randomized control trial on this, it may really prove very beneficial to the patient, where just screening them through seconds through an AI would help increase our results. I really thank each and everyone for your patient hearing, and thank you once again, Amit Patki sir and Asha Bakshi madam, for this opportunity.
Thank you, Ashwini. Chairperson's comments, please. Dr. Preeti, Dr.
Yeah.
Bindu.
Thank you so much, Dr. Ashwini. I think it was a fantastic. I think it's going to be in raptures today with so much of this thing, Dr. Madhuri Patil and then Ashwini. I mean, I think Ashwini, even you did a fantastic presentation, and there's so much more to learn, and I think in embryology, there's always more and more and more and more to be learned every time. So I think it was a fantastic talk. Do Brigadier Saab and they want to pass any comments?
No, so I wanted to
I
ask Ashwini, like, of all the things what you mentioned, what do you think is the best that would improve the pregnancy rates, like from the embryological point of view?
Madam, I
Because
still
if you look at the evidence, everything is very controversial.
controversial,
Because
true.
there are some studies which say that, okay, it helps. There are some studies which say for everything, for time lapse, for embryo glue, for whatever, a lot of AI identification and all those things. So even assisted hatching, they say that there's hardly any,
Role.
basically any role, except when this thing is, the zona is very thick and all those things. And frozen embryo transfer, probably because the zona hardening may happen because of freezing. So out of all what you said, like in your practice, like what did you find the most important parameter or a technique which has helped in increasing the success rate? Like,
I still feel, madam, that when we shifted from day 3 to a day 5 embryo transfer, that somewhere increased the pregnancy rates. And now, when we are going towards elective single embryo transfer, we are still doing the morphological assessment. We do not still have the time lapse. So I think that is what we depend on. And somewhere I feel that when we do some standardization of all these techniques, will we be really able to come out of some consensus where we can confidently say कि this media is the best, or this day of transfer is very good, or this embryo would be best? Because we tried everything. As they say that whenever embryo glue came in new, we tried doing that. After few months, we found that there's no difference. We initially used sequential media, then we moved on to one step. After a few time, we found that it gives the similar result. So I feel that personalizing these techniques as per your patient would somewhere make that edge of a better result.
yeah, I think today many of us are still into private practice. We don't have a time lapse because it's quite expensive, and I think it adds to the cost. Probably PGTA might help in a small group of patients, not in all. And there was one more thing which I forgot now.
Actually, madam, what with PGTA, what happens? No, it is really beneficial for patients who are more than 35 or 40
Yeah,
years. But
small.
in them, we get a very small pool of embryos. So the clinician is also in a dilemma as to what to do, whether transfer whatever is available or subject them to a PGT.
Yeah,
So somewhere we also have to balance the cost for the patient.
yeah. No, no,
So I
cost is
feel that
very
it's still
important.
a tight rope
Yeah.
walk for us, wherein we can definitely say something that this is the practice that has to be done.
I think probably for all clinicians, a day 5 transfer and a single embryo transfer is the best
Yes.
practice, probably what we can follow, then
Follow. True.
yeah. What about sequential transfer? Because there are some clinics who are doing sequential transfer where they're transferring one embryo on day 3 and one on day 5.
We have been practicing 2 embryos on day 5 and now a single embryo on day 5. I think that is what suits best, because somewhere I feel that you are in an era where you don't want to disturb the endometrium once you have done a transfer. So sequential transfers have never worked for us.
Yeah, but there are many people who vouch on sequential transfer in patients of recurrent implant. Anybody else over here in the forum who has experience with sequential embryo transfer?
Madam, we did a couple of maybe around 20 cases wherein we did sequential day 3 and day 5, and we got result in about 1/4 of them. But still, because of the extra work, the extra resources, and double ET, and so many things, and then not very sufficiently and encouraging results, we gave it up. Because, ma'am,
But
ultimately it boils
Professor Ariel Weisman from Israel, he vouches on doing a sequential embryo transfer. And I also know that Dr. Nalini Mahajan from Delhi does quite a number of sequential embryo transfers, and she says that her pregnancy rates are really good. I myself also do not have any experience, because what I feel is once you put in an embryo, again, when you're doing an embryo transfer, you're probably going to disturb that embryo, whichever you've inserted. So my
We
mindset
do
is
that
that
embryo transfer
I
so
don't want to.
meticulously that we don't want to touch here and there, don't want to disturb the endometrium. And here you're disturbing it twice. I mean, I don't know, somehow it still sounds a little traumatic.
Yeah,
Madam, when we used to do sequential, we used to do the first transfer used to be done slightly higher, about 1 centimeter from fundus, and the second transfer used to be slightly lower, so that we don't go to the top again.
No, but the
That-
embryo always can come down now, so we
I
don't
know,
need.
ma'am, it was just a matter of just thinking. And ultimately, we gave it up, ma'am, many years back. Many years back. So after that, we never started it again.
Yukti has to say something. Yeah.
Yeah,
You
yes,
also.
ma'am. Just I wanted to add that some people do have a very good experience with sequential embryo transfer. They believe that when we do the first embryo transfer, it creates it increases the levels of the inflammatory mediators, the good mediators which are needed for the which will help in the implantation of the second embryo. So
Like a
these prostaglandins and all, which will help in the implantation of the second embryo.
thing like
So some people do have good experience with that.
so Yukti, you're talking about something like a scratch thing, no? Like
Yes,
like
ma'am. So yeah, something like that.
But scratch does not have any evidence. A multicentric study all over the world has shown that scratch is.
Yes, ma'am. Even sequential embryo transfer is not having much, but some people are having good experience with it and they do it.
Yeah, I also know.
yes, Bindu, ma'am.
Yeah, can I add?
Yes,
So,
ma'am.
excellent lectures. I've heard both of them, beautiful lectures regarding the sequential transfer. It all boils down to, does it significantly increase pregnancy rates? Sequential transfer. Secondly, it increases the cost. We are doing twice embryo transfers, then the availability of the embryologist. So, the paying capacity, all this, I mean, the centers where they have a in-house embryologist full-time and paying capacity of the patient, that also makes a difference. And then when we are talking of now single embryo transfer, how does it make sense to do a day 3 transfer and then another day 5 transfer? So I mean, it doesn't really make sense. And like Dr.
No, but I think people who are doing it, they're doing it only in patients with recurrent implantation failure. They're not doing it in all patients.
Okay.
So I'm not very sure, because I myself don't have much
I mean,
experience.
we really don't have enough data probably to substantiate the use of double transfer technique.
Somehow, Madhuri madam, I always feel that just transferring one embryo on day 3, I mean, how would it give you a result? Now, otherwise, also, we would have practiced this single embryo transfer of day 3, which we have never done. So it must be probably that day 5 embryo only which must be implanting.
So what we are effectively doing is, in order to get a pregnancy rate, I mean, when we say pregnancy, we are talking about live birth rate. In that process, we are reducing the implantation rate. So maybe you are not transferring on day 3 a single embryo. You might be inclined towards transferring at least 2 embryos on day 3 and then a blastocyst. So per cycle, the number of embryos that you are transferring increases. And so your implantation rate goes down. So you're wasting embryos also in the process.
No, they normally transfer one on day
One
3 and
embryo.
one on day 5.
Okay.
Means that's what Dr. Ariel also does, and that's what Dr.
I don't think in India people must be doing that. I
No.
mean, okay, yeah, that's interesting, but
I want to share, it may just be a coincidence, I'm not sure. But yes, in a few patients I have tried where there was a failed implantation earlier, and doing a sequential transfer did give results. And that encouraged me to change my protocol a little in some patients. On the day of 2 days prior to the embryo transfer, I would just take an IUI catheter, just do a mock transfer, or maybe use an embryo transfer catheter, just do a mock transfer, deliberately just touch the fundus and come back, and then do the embryo FET on the third day. So
No,
that
but
also probably
if you
gave
look
good.
at the results, even where initially they were advocating scratch. So what they
Yes.
said is that if you do the scratch in the same cycle, or you do a hysteroscopy also in the same cycle as you're going to do an embryo transfer, the same, it has shown that though there might be a pregnancy, it increases the chances of miscarriage. So there are, I think at least I've read 4 or 5 papers who have looked into this, and they have said that doing either a hysteroscopy or a mock transfer in the same cycle as the in your transfer cycle definitely increases the miscarriage rate. So
Okay.
I don't know what is your
No,
experience.
I've not done many, but yes, a few cycles I have deliberately done it. And one more question to Dr. Madhuri Patil, ma'am. What is your experience of error? Many people are doing it. I'm not convinced though, but if it comes
No,
from you, maybe
I have done in about 40 to 50 patients, and I found that it really didn't help, so I've
that
stopped
doesn't
doing it.
help.
I don't.
Okay. Okay. Thank you.
Madam, what you said is, I mean, double embryo transfer different, but mock transfers, yes, certain papers do recommend doing a mock transfer.
No. So, but mock transfer in the same
On
cycle
the day
as
of
your embryo
embryo
transfer
transfer.
increases the miscarriage rate.
Yes, may.
Thank
So
you.
I think that brings us to the end of the academic, the lectures, the keynote lectures by Madhuri ma'am and by Dr. Ashwini Kale. Very well presented and very well discussed. Thank you to both the speakers. We are grateful for your time and contribution to ISAR Perfection series. And now I hand over again the third session to be conducted and started by Ankita and Payal. Let us be very brief with the CVs so that we can start the discussions.
Monica, I'll just leave and I'll join again once I reach the clinic, okay?
Sure, madam. Sure, ma'am. Thank you so much, ma'am.
Thank you, Monica, madam. I'll be here only.
Thank
Yeah,
you,
sure.
Ashwini.
Please be
Thank you,
there.
Ashwini. Okay, so Ankita, all
So,
set?
yes, ma'am. We now move to the panel discussion session of our webinar, and the panel will be on troubleshooting in embryo transfers. And we are privileged to have with us an esteemed panel of experts who bring vast experience, academic excellence, and practical insight to this discussion. I'm sure their collective wisdom will enrich our understanding. So, the moderators for the session are Dr. Monica Singh ma'am and Dr. Randhir Singh sir. And the experts that we have for today are Dr. Bindu Chimote ma'am, Dr. Chaitanya sir, and Dr. Prerna Shinde ma'am. Next slide, please. I would like to introduce Dr. Bindu ma'am first. She's a senior consultant clinical embryologist, and she's a secretary of IFS Vidarbha chapter 2024-26. She has several original research paper publication and is a co-editor of in the handbook of textbook of IVF. We welcome you, ma'am. Next, we have Dr. Chaitanya S. Ganapule, sir. Sir is a chairperson of FOXY Endocrinology Committee. We welcome you, sir. Our next expert is Dr. Prerna Shinde, ma'am. Ma'am is the director at Shinde Hospital and SUBB Center, Sri Ram Nagar, and ma'am has an experience of over 3 decades, and she has been practicing infertility for over 2 decades. Madam has areas of work interest that encompasses infertility in various ways, and ma'am has various awards to her accolades. We welcome you, ma'am. We now come to our galaxy of panelists. We have 12 panelists today, starting with Dr. Ananta Lakshmi ma'am. She is an ASHRAE and American College certified embryologist, and she is practicing in Trichy, Tamil Nadu. She has many awards to her credit. We welcome you, ma'am. Next, we have Dr. Kanika Kalyani. Dr. Kanika ma'am is a leading fertility specialist with over a decade of experience in ART, and she has a vast clinical experience in IVF. We welcome you, ma'am. Next, we have Dr. Mahima Lalwani, ma'am. She is a consultant obstetrician, gynecologist, infertility specialist at Lalwani Mother and Child Care Hospital, Pune. She is a recipient of many awards and has vast clinical experience. We welcome you, ma'am. Next, we have Dr. Mugdha Bamre, ma'am. She is an experienced fertility specialist with over a decade of experience in reproductive medicine. She has many specialized trainings and fellowships done, and she has a vast experience. We welcome Mugdha, ma'am. Next, we have Dr. Faizan Mistry, sir. Sir has a great training in reproductive medicine and minimal access surgery, and sir is practicing in various hospitals in Mumbai, and he has many awards to his credit. We welcome you, sir. Next is Dr. Rachna Samir Deshpande, ma'am. Ma'am is a reproductive medicine specialist and a cosmetic gynecologist. She is a director and chief fertility specialist at Infinity IVF and Fertility Center. And she's a director at Infinity MediSurg and Infinity Prime Speciality Hospital. We welcome you, ma'am. Next, we have Dr. Riddhi Joshi. Ma'am is a gynecologist and fertility specialist practicing in Mumbai for over a decade, and she's a recipient of many awards. We welcome you, ma'am. Next, we have Dr. Rinoy Sridharan, sir. Sir is trained in reproductive medicine, gynae endoscopy, fertility preservation, and for NT-scan. Sir has various publications in national and international journals, and he has various awards to his credit. We welcome Rinoy, sir. Next, we have Dr. Shilpa Bhandari, ma'am. Ma'am is a consultant for fertility solutions, gynae endoscopy, and robotic surgery, practicing at Indore, Madhya Pradesh. Ma'am has many publications in indexed national and international journals. We welcome you, ma'am. Next is Dr. Surbhi Gupta, ma'am. Ma'am is a reproductive medicine specialist, senior consultant, IVF and reproductive medicine, practicing at Gurgaon for over 15 years. And she is a first author and peer reviewer in various textbooks. We welcome you, ma'am. Next, we have Dr. Vanshika Jain. She is a senior clinical embryologist and lab auditor. And she is a national conference faculty at many conferences, and she has many awards to her credit. We welcome you, ma'am. Next, we have Dr. Yukti Bharadwaj. Ma'am is also a reproductive medicine specialist, currently practicing at Benison IVF, Noida. We welcome you, ma'am.
Thank you for the kind invitation and introduction. Thank you so much.
We are delighted to have the galaxy of panelists, and we actually are awaiting for an eminent panel discussion. Welcome to all, and now hand over it to Monica ma'am and Randhir sir for the moderation.
So thank you, everyone. And Bindu madam is there as an expert. Bindu ma'am, I would like your wholehearted inputs in between the panel. You have the freedom to ask any question, be a moderator along with me. And hello to all the panelists who are there, Mugdha, Shilpa, and Kanika, Rinoy, Riddhi, Rachna, Yukti, Parzan. Yeah, that's it. And it's quite a handful. So welcome to you all. Let us start.
Just if I can say at the outset, the honor, of course, is all yours to moderate the panel. I would like to congratulate you for such a wonderful series. So the perfection series is really focusing on perfection, because the time that you are devoting to each topic, and you're giving just 2 lectures, half an hour session, that gives ample time for the subject to unfold. Otherwise, 15, 20 minutes rush around and then you're giving even time for discussion. So that is really commendable. Congratulations to you. And if Dr. Randhir is not here, we'll miss him really. But it will be a good session, I'm sure, and looking forward to this. Thank you.
No, he cannot be missing. He will surely join. But he has a habit of coming and going, coming and going. So I can't really pinpoint where he will be at this point of time. But I'm sure he's going to join us in between, madam. And let me just start. Can you see my slides? Are the slides visible?
Not yet.
They're not visible?
No,
Not yet.
No,
No, ma'am,
just
not. We can just see
a
embryo
taskbar
transfer.
is there.
Yeah, just
Embryo transfer PPT.
Okay. I can see the PPT. What about now?
Screen is split. I think just close it and open it
yeah.
again because the screen is split.
We can see half and half and a black screen. So maybe
Yeah, the laptop is really. I'll stop share and start again. Actually, in the process of presenting this webinar, I forgot where I kept the PPT. So, Anmol, can you help me here?
Yes, ma'am. Can you first open the presentation on your device?
So, what about now? Can you see?
Now we can see, ma'am. Ma'am,
now we can see the PPT. Yes, ma'am.
Right.
put on the slideshow.
So I troubleshooted the embryo transfer. So coming to troubleshooting in embryo transfer, and you can see these beautiful embryos moving around the screen, trying to implant, and that is what we are targeting. That is what we have been trying to get the message across the last 2 hours. Your moderators for the evening, Dr. Randhir and myself, humbly asking for your support during ISAR Managing Committee elections, which are in January. Please meet our experts, Dr. Bindu Chimote, Dr. Chaitanya Ganpule, Dr. Prerna Shinde. Dr. Bindu Chimote is a very senior, renowned embryologist in Nagpur, and she has been the presenter of several original research studies along with Dr. Natachandra Chimote, very close friend of ours, and very inspiring work Madam has been doing over the last decades. Our panelists, all alert, bright, and very eager to contribute to the panel. And trust me that you will be talking more and I'll be talking very less. So we will walk you through all these aspects, the procedure of embryo transfer, how you counsel the patients, the types of catheters, embryological aspect, the clinical aspect, which factors definitely affect the success, which factors are there but not that important, the difficulties you encounter, how to overcome those difficulties, and what does the future hold in store for us. So we all know just putting embryos inside the womb is not ET. ET is actually the most crucial penultimate step in IVF procedure where we spend weeks in preparing the patient, doing the oocyte retrieval, making the patient comfortable, everything. And then if you mess up the embryo transfer, you have basically, ruined the chance of a pregnancy and also spoiled a good cycle. So we have to select the best seed, prepare the soil, and plant at the appropriate time using the proper care and technique. So just tell me, any of you, that how can we actually achieve this embryo transfer optimally? And what sort of embryos do you want to transfer in 2025 to 2035? What are the types of embryos? What stage of embryo would you be transferring in the next decade? Any of you can answer any question. So this is on the screen, all the embryos for you. And which ones would you transfer? Which ones do you think will increase your success rate?
Yeah. Good evening, madam.
We just heard Dr. Ashwini saying that even cleavage stage embryos give you result. But when clinic success rate goes down or dips, they try to find the most optimum way to raise the, that success rate. So which stage of embryo would give you the best results?
Definitely, a day 5 embryo has been associated with higher pregnancy rates, a hatching blast or a hatch blast. So, for my preference will be a day 5 embryo, ma'am.
So
Uh,
you're
me,
getting,
al-
yeah, please continue.
Me also in moving forward in the next few years, I think a single day 5 good grade blastocyst is what we would be aiming for. This is not just for achieving the good implantation rate, but we are also looking at having a very peaceful antenatal period also, and to avoid as far as possible to reduce the risk related to multiple pregnancy. So given our labs and everything being very advanced, and having worked with such skillful embryologists, I think we are all going to be comfortable with this concept moving forward.
I
Uh,
Yeah. I would like to ask the panelists that now
I'll
you are clearly encountering AMH as low as 0.5, 0.7. Less than 1 has become the norm nowadays. And
Dr. Monica,
so
just I want to clarify the one thing is that whether the day five, because our topic is embryo transfer. So whether day 5 transfer are superior than day 2, day 3, so that question has to be answered to the all audience. So my view want every all panelists please give your views. Then I'll get in the end I'll conclude with the Cochrane data.
I would
Day
also
five,
like
surely,
to totally
based on what
support
we've been practicing.
everybody else. Day 5 always better, and preferably going forward, we would like to go for a single embryo transfer. But if the woman's age is above 40, and we have not done a PGT, I would go for a double embryo in that case.
So I completely agree with Dr. Kanika because when we are in the era where the AMH is actually falling and we are encountering more patients with AMH less than 1, which patients we are going to actually put in 1 embryo and 2 embryos should be kind of decided. So the people who are with multiple failures or maybe who have had recurrent miscarriages, yeah, if you have a PGT tested embryo, a day 5 embryo, a single day 5 embryo would be the best way out to go. But if you have previous failures, then I would still be comfortable in transferring 2 embryos to blastocyst in that case. Now, going ahead with again a day 3, day 4 versus day 5, it also depends upon the oocyte yield and the embryo formation which has come out in a single cycle. So if I see that the patient is around maybe say young patient who probably has a good endometrium, and if I feel that I've got probably 2 day 3 embryos and I'm a little bit skeptical about the embryos then going to blastocyst phase, I may still go in and do a day 3 day 4 transfer versus a day 5 transfer in those patients too.
yeah, that's what I'm trying to say, that though we all vouch for a day 5 or a blastocyst transfer, sometimes the number of embryos you get the number of oocytes are so less that sometimes the cleavage stage at you got a total number of oocytes which are 3 or 2. Would you like to culture them to day 5 and risk the arrest or risk a no transfer scene where you have to say the patient that there are no embryos left to transfer? So there are very many studies. In fact, we had a senior speaker in our program, Dr. Jatin Shah, who was speaking actually on ovarian stimulation, but he gave data from his clinic which has got number of cycles wherein he has come back to cleavage stage transfer and he has come back to fresh transfer. So now to resolve this dilemma, I will ask our expert Bindu madam to comment.
Yeah, thank you so much, Dr. Monica. As all the panelists said, so the clinician perspective and the embryologist perspective. As an embryologist, every embryologist would want to develop blastocyst, culture blastocyst, and transfer blastocyst. And we tend to incline towards saying that blastocyst gives better pregnancy rates. And when we talk of single embryo transfer, it is better to do a blastocyst transfer and better selection of embryo with a blastocyst transfer as against the day 3. But looking at evidence whether day 3 or day 5 is better, now the results are there is no equipoise. I mean, there is no equipoise or to say that one is better over the other. There are clinics now that are moving back to day 3 transfer. And as you rightly pointed out, if we are talking of more and more number of patients coming with low AMH, premature ovarian failure, these are the patients that probably need a blastocyst transfer. But there is a fear in the mind of the clinician also whether we can really go for blastocyst and to face the scenario of no blastocyst available. So since day 3 does not give any less pregnancy rates compared to day 5, we would prefer a day 3 transfer for POR patients as well. So the choice is with respect to the clinic, but day 3 is not any less as compared to day 5 transfer. Day 5 gives better selection and single embryo transfer is possible.
So this is
Ma'am,
what
sometimes, yes, just can I add one thing, ma'am? Sometimes male factor infertility in which the quality of sperm is very poor. They are also associated with cleavage stage arrest. Embryos are arrested at the cleavage stage. So that is one more indication when we have to consider a day 3 transfer because there is high chances that the embryos will get arrested and we won't have any embryo on the day 5.
So that's what some people argue that if it does not develop into
Does not.
blastocyst,
It will
it
not
would
give
not
us.
implant even otherwise.
Exactly.
But then at the same time, it is the clinician's now prerogative because you have to counsel the patient. And there are instances where the patients are ready. Even they do a lot of Google survey and they say that we want a blastocyst transfer. We are prepared if no blastocyst is formed. Or
And I
there
think
are
it,
some patients who do not understand, who want a transfer, come what may. So then even, I mean, there are instances where we have gone ahead even with a day 2 transfer where we had only a single embryo. And I mean, not frequently, but yes, they also give implantation and pregnancy. A single embryo transfer on day 2.
and I think that also depends upon the grading of the
Right.
embryo. When you're seeing a day 3 8 cell grade 1 embryo, the probability of this embryo to go to blastocyst, if we have 2 or 3, we can still keep it for a blast culture and probably see. But when you have a mixed bag of embryo, maybe a 8 1 by 2 or maybe a 8 1, then probably you might be skeptical in those areas. And I think that is why you're morphologically, looking at your embryos and grading them is very, very, very important as to decide what stage of embryo transfer you're going to be doing.
it boils down totally to the number of embryos, the morphology of the embryos. And as our expert has rightly said, what I wanted to impress upon the young clinicians is that we are basically getting better selection by culturing to blastocysts, and we are reducing the chances of multiples. And
Uh,
that gives you confidence. But at
yeah,
the time, the implantation potential of a cleavage stage embryo is also very good, and uterus is the best incubator, actually.
Yeah, I think Dr. Monica, you have done very good, and the expert Dr. Bindu Madam has toned very well, and Farhan also very well. So I think as we have shifted Dr. Monica in last 25, 30 years practice, now it is not a general, we started from the agonist, the antagonist, and then we have to do transfer multiple day, 2 embryos, 3 embryos. So now I think coming to this, now it's individualized, tailored patient stimulation protocol. So now the embryo transfer also should be, as Bindu ma'am told and Farhan told, that it has to be depending upon the individualized, that how many oocytes and how many embryos you have at day 2, day 3. But I'll focus to you all the people that as the Cochrane also, remember Monica, if you remember 3-4 years back, we had presented a paper in Russia, Germany, that our day 3 embryo transfer versus day 5 transfer were same result. And the Cochrane data also says that whether you do day 5 transfer or cleavage stage, the end live birth rate is the same. So I think that will conclusion will go ahead. Thank you.
Okay, so I think we proceed. So there are
Yeah.
no actually evidence and consensus on technical aspects of embryo transfer. Let us move to that. There are lots of idiosyncrasies that people have. Many recommendations are not necessarily evidence-based. So now anybody can tell me before embryo transfer, you're all busy. You're busy with multiple stimulation cycles, your ultrasound. Many of us do obstetrics also, gynae also. I'm sure Yukti must be running between clinics, and Parzan has got a heavy practice. So, do you educate your patient before a transfer, or you tell your nursing staff to do it? What do you think of your attitude and the patient's attitude and her general composure? Does it matter?
Ma'am, I think in this case,
Definitely, ma'am, it matters.
it's
Definitely, we have to reduce the anxiety. We have to tell the patient, the couple, the importance of stress. That the ultimately the stress does affect the embryo transfer results. So we have to talk to them, spend time with them. That like they should not worry about the results all the time, and they should try to stay positive as much as they
I
can.
think
We
the
have to spend
easiest
time
way
with
to
them.
counsel them how the embryo transfer would be to do a mock embryo transfer one cycle prior on day 21 if they've never had an embryo transfer before. So in that case, the patient becomes confident that it's going to be a painless procedure. So I'll be able to see the catheter movement. And then on that day with the optimum bladder full, once you go and just beat them and greet them for 30 seconds, all their stress is gone.
In fact, I was just watching on YouTube and suddenly this embryo transfer video came of a renowned practitioner in Mumbai. And he is doing ultrasound guided embryo transfer, one machine for himself. And he has a huge monitor hanging from the ceiling for the patients to watch.
Patient to see.
So, in fact, that's a very good idea if you can, have, because the patient is all the time seeing the screen, so her stress, because you have got your senses glued to that. So you forget to tense your body or forget to think, or maybe some diversion techniques, some music or something. But these are all meant to calm down the patient and reduce the uterine contractions, which Madam said, Patil ma'am, Madhuri ma'am had told us about. Of course, you should have a proper consent and data and everything. Check the documents, never skip this procedure. More important for the embryologist. Now, how much full bladder is a full bladder for embryo transfer? Whether you would like a just filled, what do you call a just properly filled bladder? The patient, you tell the patient, the bladder should be so much so that you are comfortable. So, do you tell the patient to drink water and come from home? Or should you tell the patient to come totally empty bladder and start having some fluid in your clinic? Do you want her to have the urge to pass urine when she goes in? Because once she goes into the embryo transfer room or your OT, till you do the embryo transfer, again, there is a lapse of 15-20 minutes. The lithotomy position, everything. So, how much full bladder is actually full bladder with which you are comfortable?
So I
So
think the bladder which just touches the fundus of the uterus, I mean, that is something which I would consider as a optimal bladder for the embryo transfer. Again, like you correctly pointed out, madam, that that by the time the patient goes into the room and the lithotomy is given and the painting is done, and by the time I generally do a an after loading technique. So by the time the outer goes in, the time the inner goes in, and there is a lag in that, we make sure that the bladder is so much so that it's not completely full, also patient is comfortable, and it's just par the fundus of the uterus, so that once the process is started, the uterus comes into the straight line when we put in our Cuscos or a Sims, and we can be very very easily negotiable with the catheter inside.
Yeah.
so
So,
And
my
it also depends on the position of the uterus. So if it's, a normal anteverted uterus, it should be up till the fundus. If it's acutely anteverted, sometimes we have to tell the patient to fill it a little more so that the uterus becomes straightened. And if it's, retroverted, in fact, we need a little less than
As a
bladder.
Yeah.
less full
That,
bladder.
it's not difficult to put the catheter inside.
yeah,
So
you
Should
know,
be
usually,
partially filled.
my standard practice for the bladder is just I keep it very simple. Patient usually comes to the clinic at least a hour before the embryo transfer, 1.5 hour before. So first we tell her to empty the bladder once she is at the clinic. So first of all, they are relaxed. Then she starts drinking water, and then there is a time in which the nurse will take the patient to the ultrasound room. We'll check the bladder and see how optimum it is. And as rightly said, the optimal bladder is where we are able to see the cavity, the uterine cavity, and the catheter path being straight. So that is just enough. There is once that point is achieved, the rest of the by that time the OT and everything is ready, and then the patient is
taken in the embryo transfer procedure room. So that is usually how we do it, and patients are quite comfortable, because if they come already with the full bladder, then vapis we have to empty, then again full. So once it's empty, and then we have that much buffer time that we keep, so that we can manage the bladder situation. And a semi full bladder, as per the anti-version and retroversion, so that usually takes care of the optimal condition for doing the procedure.
Yeah, so if you go to the OT and you see the image on the right, the bladder is suboptimally filled and you can barely see the fundus. Even the endometrium is not visible. It's the lines, and this machine is quite hopeless. I think we have better machines now. So what you do is don't try to shift the patient out that time. She's already had about a liter of water and come, because these patients, you ask her to have, about 500 ml of fluid, she'll have 4 glasses of water. Okay. So just give her time. By the time you get your positions ready and everything, this bladder will come to the other stage. Now, suppose you get the patient, you have given the position, everything, and your nursing staff has set it up. Now you come, you put the probe, and you find a distended bladder in OT with positions on. Do you make the patient go out, pass urine? Do you make her pass urine partially? Do you tell her to empty bladder completely and then wait? Or would you dare to pass a catheter?
I prefer to pass, I send the patient to pass the urine rather
And
than that's
yeah.
what I prefer to do because they're more comfortable doing that. And unnecessary catheterization should be avoided, is what I've learned. Because out of many patients that you catheterize for, one of them will get a UTI. And using some sort of antiseptic or something to, to clean that area, it's not a wise thing, is what I feel based on my personal experience. And another thing was when we were discussing about bladders, there is one condition that is when you have a ventrofixed uterus, post a cesarean section or some laparotomy. So those are the conditions where you do not need a full bladder many a time. You just need a very small bladder. Sometimes I've done on empty bladders also because especially in the thin patients, you just have to stay away from the scar and angle the USG machine in such a way that you can see the actual tract. The only other point being that since your cervix is quite stretched out, if your soft catheter, if you're using it, if it has a stop mechanism, then you'll have to push it all the way back because it's going to be a rather long cervical tract. So that is one thing. And once you go up to that level, you'll have to probably turn it 90 degree, means 180 and make it retroverted so that you don't go and end up in the scar. Because at that point, there is going to be some hypoechoic lesion. Means that area is going to be there. That will misguide you many a time, and you will immediately get blood in the outer catheter. So
Talk
again,
about We'll
yeah,
talk about difficult TTs also, but Dr.
yeah.
Renoy is very correct that scarred uteri, previous surgeries, previous myomectomies, previous, any other procedure, sometimes like Madhuri ma'am showed us, you cannot see the endometrium continuing from the cervical canal, and sometimes you just see the fundal stripe. So you have to then just make the passage as smooth as possible. Have a good ultrasound, which will just tell you where you have entered that fundal stripe, and try to deposit the embryo in the most optimal position. This usually happens with a previous section, a previous myomectomy, any other surgery, or a ventrofix uterus, and those cases are
Yeah, I
difficult.
would like to support this for one more reason, that in such ventrofixed uteri, sometimes when we put the speculum, like we use the Cuscos usually, so the cervix is pulled up so much if the bladder is full. So we need, all the more we need, a little empty, partially filled or less than partially filled bladder, so that the cervix is visible. Otherwise, it's sometimes so much pulled up that we can't visualize the cervix also. So in partially or less than partially full bladder, it's easier to visualize, and then we can do the embryo transfer.
What tables do you prefer? Do you have the conventional tables with the stirrups and that leg rest, or is anyone using a chair? Now you're getting, like I just saw in AICOG, I wanted something like a very comfortable chair for one of my patients came from a metro city, and she said, "Madam, you've got a table. I want a chair. I want somewhere I can lean like a dental chair high up, and I can use my mobile, I can all those things." She demanded. So I, went all through the AICOG stalls. looking for that perfect chair. And I did get a design, but it was quite low. So I told them to customize it. But right now it is like the price is exorbitant. So is anyone using a comfortable chair-like couch for a patient for the embryo transfers, the ones which are available in Western countries? Shilpa, since you have a medical college, anything like that?
Yes, ma'am, we do have a chair, but because we share the same lab for our pickup also. So doing pickup is not possible on those chairs.
Yeah.
So we have actually customized our table. So it's a split kind of table and we have customized it. So for embryo transfer, it appears like a chair. But when we have to do pickup, we can just simply extend it completely and the patient can lie down flat so that the anesthesia people don't have a problem. And because it is electronically moderated, so it can go up and down and the patient can simply sit like this, sit on a recliner. So basically for embryo transfer, but it is something that we have done for ourselves. We have combined a dental chair with the labor bed that you have actually.
Exactly, exactly. So that is it. When the patient demanded such a chair or table, I was really curious as to how we can, customize or design. And sometimes embryo transfer, you want the patient to be comfortable.
We
So
have
I
the same thing in sonography also, so the patient is aware that how they have to sit and where they have to go.
In fact, I was going through a website of a prominent IVF chain in US where they advise the patient to wear warm socks and keep their legs warm. I mean, this is the keeping their body warm and cozy is one of the ways where they can, have an optimum transfer and an optimum experience at embryo transfer. Now, in our country, we tell them remove all socks, remove all stockings, leggings, everything. We want all sterile drapes. And what temperature do you keep in your pickup OT as well as your transfer OT? Is there any difference? There you're dealing with embryos, here also dealing with, there you're dealing with gametes, here you're dealing with oocytes. So, Bindu ma'am, can you guide us as to what is the optimal temperature of your laboratory as well as the adjoining OT?
It has to be room temperature, 22 to 24 degrees, whether it is your embryo transfer room or your laboratory. The lab temperature, 22 to 24.
Ma'am, 22 is good enough for embryos?
Yes.
It's like I feel sometimes 22 also becomes a little
22 to 24. I mean,
right.
that is what I mean. The recommendations also suggest 22 to 24.
Yeah, because you're transferring the embryos within 10 to 20 seconds once you are
Yes.
loaded. So it really does not make a difference unless it's a difficult transfer, wherein then you're doing an after loading. So you should load the embryos into the inner catheter only once the outer catheter is in the cervix.
Ma'am, Ashwini showed a slide
So
where she
still what we do is, I mean, it has been suggested, but then if there is an AC in the lab, in the embryo transfer room, we switch it off. In case there is, I mean, now it is no one has an AC. You have the AHUs and all, but if there is an AC, we switch it off.
But the AHU does not need to be switched off, Bindu ma'am?
Yes, we do. That too.
That too, no? Yes, yes. So Ashwini showed a slide, I think, in which she said that seconds after taking out the embryo from the incubator, whether it is the conventional big incubators or the benchtop, the temperature of the embryo goes down by 10 degrees. So does it cause an embryo shock?
No, no, I don't think it goes down by 10 degrees immediately because you're covered it by oil. So that's the reason why you're covering the embryos by the with the oil, and therefore the temperature fall is not that much.
No, 1 degree. 1 degree.
Yes, yes, 1 degree. Yes.
It's 1 degree,
And
it's
then
not 10
only
degrees.
thing is the difference between a conventional and bench top is that once you place them back inside, the temperature comes back to normal in a bench top much earlier than that in a conventional. Conventional, it takes almost 2 hours for the temperature again to reset. And therefore, now I think today, I don't think people are using conventional for embryo culture. They're using just for warming of the media and all and equilibrating the media. So basically, it is.
So that
No, so Dr. Monica, that the thing that you're talking about, it is removing from the incubator taking it on your laminar, inside your laminar, which again is maintained at 37 degrees, and loading. So that there won't be a drop of 10 degrees, definitely not even 1 degree, if your positioning of your incubator and your stage is close by.
And I think the 10-degree in her slide must be the
Oh, no,
Fahrenheit.
I had showed one slide where it said, I said, if your embryo transfer does not happen within loading of the catheter and depositing the embryos within 120 seconds, that is 2 minutes.
Yes.
Then there is decrease in the temperature. That also, I mean, that also it depends upon the timing. So if you've done it immediately, it really does not make a difference.
Yeah,
Only
ma'am.
if it is exposed for more than 2 minutes, it makes a difference.
I think you have more such questions later where the timing of transfer, because it all depends on whether you insert the outer catheter first and then load the embryos when the catheter is all set, the outer one. Then I mean, for us, that is the practice we follow. The clinician then says that, okay, we are ready now. And that is when we remove the embryos from the incubator, load it in the inner one and take it for transfer. So only after the outer catheter is set do we load the embryos.
Okay, so that brings us to another important question. After loading or preloading? Preloading means that.
Preloading basically only if you know that it's a easy transfer, that's all.
Yes.
So, ma'am, when
After loading.
I started IVF practice in 2005 in Bhopal, and that time the most popular embryo transfer catheters were Wallace, the pink, the soft catheter. And we used to have that whole assembly and go and come out. And then gradually we realized that this is not the, ultimate, because you get so many difficult transfers which Wallace cannot overcome. Then we came to other. Madam, so now after loading is the norm of the day nowadays?
Yes, most of them do that. Very few, like Madam rightly said, only when you expect an easy transfer do you do the preloading. Otherwise, it is after loading.
So basically, when you're transferring the embryos, you're doing the ultrasound. So when you're doing the ultrasound, you know that it's going to be easy or difficult. If you see that the cervix and the uterus is in the same straight line, you can just do a preloading. It really does not make a difference. But when you know that no, the angle is different, at times you cannot see the cervix and the uterus in the same line, or you have already done a previous IUIs, or you've done a hysteroscopy for and you have found out that there's difficulty in dilatation or difficulty in identifying the thing. In these cases, it's best to do a afterloading. So basically, it has to be personalized depending on the findings.
Also, the
the old
chances
school
of the
people still
catheter
do.
tip being contaminated with the cervical mucus is reduced in after loading.
No, nothing like that. Your inner catheter is inside, yeah. That is preloading is always like that. It's only your outer catheter that touches the cervical. It goes through the cervical canal and into the internal os. Your inner catheter is always inside. It's only once you see the tip of the outer catheter at the internal os, then only
Then you start
insert your this thing. And therefore, normally if you have a Cook catheter, it has lines on it. So you've anyway taken the uterocervical length, so you know what is the cervical length, and you need to adjust the stopper as well as that according to that. And then once you put in, it has those centimeters on it, so you know at where you need to stop, so that you're almost 1 to 1.5 centimeters below the fundus.
See, all the old school people still do a preloading, and like Dr. Yukti asked, the inner catheter is inside. It is not protruding out from the outer one. So once it is there set, then they start pushing the inner one according to your cervical canal length.
Yeah.
And then after loading, we also need a good skilled embryologist, so that the time between loading and the transfer is preferably less than 60 seconds, and otherwise less than 120 seconds. That's also very important in after loading.
So in my setup, the embryologist.
What difference it makes here after loading? It's not like that. So once your outer catheter is inside, it's fine. The embryos are not exposed, because the embryologist is anyway going to load it, whatever, whether you're doing a preloading or a afterloading, it's going to take the same time. It's only the ease of insertion which is going to determine whether you're going to do a preloading or afterloading. So if your catheter, the outer catheter is not at the internal os, then only time frame is going to increase. And the embryologist is not going to transfer. It's a clinician who is going to transfer the embryos.
Yes, ma'am.
But the embryologist pushes the syringe. Actually, that would be more advisable.
No, I don't think so. I don't think so. I've been practicing for last 30 years. So it is I who do it. I don't allow the embryologist. They just get a catheter, that's all.
And
Because
madam,
I do both embryology and I also do clinic. So I know whatever embryology is also. So therefore, I'm very particular in whatever it's being done.
So, ma'am, that's
But
the
in
thing.
that
I mean,
totally
experienced and old school, all people like Dr. Jatin Shah, whether you talk of Dr. Chimote also, Dr. Madhuri Madam, Monica Madam, you all probably still follow the norm where you do a preloading, you push the piston yourself, the syringe. But then I have seen an instance where a new clinician was doing embryo transfer and she did not know, because what we load is just about 30 microliters, and she did not know she pushed it so hard that the syringe just blew off. So that is the
No,
time
so
we realized, yes.
basically this is because of so many people coming out just with 4 days, 6 months courses who really don't have any hands-on experience just because they want to open their opening clinics. And this is what is spoiling our entire fraternity of ART. I'm very blunt on this. And it is very important that we have to know that these patients are so stressed because they have infertility for so long. And if you don't know anything, I've seen people, senior people also who just started IVF clinic, they're giving a long agonist protocol, then they're giving an antagonist, and then they're giving a agonist trigger. How does it work? So I think unless you have a knowledge, people should not go into that practice because you're fooling. I mean, you're fooling yourself and you're fooling the patient. And I think that counts in your future, whatever you're doing. The money is not everything. I think giving ethical and evidence-based practice for the patient is the most important thing today in the ART. With so many clinics, people not knowing anything, just opening clinics with the 4 day certificate and all is just bullshit. I'm the very blunt on this. I see patients who have failed 100 times and who have come to me, and when I see the prescriptions or I see their papers, I've seen what is being done. Many a times nothing is given to the patient. Patient doesn't know also what has happened to her.
yes, madam is very right. Today, Madhuri ma'am has given a very important message. The multitasking that the young gynecologist is doing today. Remember that fertility practice is a dedicated practice, like fetal medicine, like gynec endoscopy. You cannot be the master of all the trades. You are a human being. You can work 18 hours, you can work 16 hours, 14 hours, but you cannot do the work of four people in one day without getting tired, without getting flustered, and that tiredness will reflect in your work.
More than that, knowledge and experience also is important, Monica. Like
Madam,
for me, I have left my obstetric practice long back. I don't do any obstetric practice. I'm totally dedicated to this. And I know I teach 3 times in a week, 4 to 6, and I know what knowledge they have. I teach for 3 hours every day from Monday, Tuesday, Wednesday. And I know what knowledge they have. What is taught on Monday, they don't know on Wednesday. So that
yes,
is what it is.
Absolutely true.
I'm very blunt because I waste so much of my time teaching. What is the use if they don't learn
and
and
these
do whatever they want to do?
These 6 months courses are not the way to learn. These 6 months courses are just a sort of,
It is just an overview where you just learn ovulation induction protocols. There are people who go to this Dubai, everywhere. They do a 4 day course and then they start a clinic. What is all this? You're fooling your patients. ऊपर वाला देखता है अगले जन्म में या इस जन्म में आपको जो होगा वो देखेंगे फिर लोग.
मैम एआरटी लॉ में तो 3 इयर्स का
Absolutely true,
एक्सपीरियंस
ma'am.
चाहिए, तो
That's
इंडिया में तो 3
absolutely
इयर्स
true.
का एक्सपीरियंस तो चाहिए.
True, true. But the message is very loud and clear that whatever you love to do, whatever you are passionate about, first of all, be perfect in it. Devote time, money, your personal attention to it. Do dedicated practice. If you want, you can do something else also, but don't try to fit in four things in your schedule. Try to outsource certain things. If you have a patient, you want to take up part in obstetric career of your patient, learn to outsource so that when she is in labor she can reach your friend's nursing home. If you want to do, you can do an elective cesarean for her. If you want to do, you can go to the labor room for her. If you want to do fetal medicine, please devote 2 years to fetal medicine. Then you have to give a large part of your time to ultrasound. And ultrasound reporting is no joke. I do tons of ultrasound, and half of my day is on ultrasound reporting. Other half is in teaching. Rest is my IVF practice, which is not a very big part. So Madhuri ma'am is very right. The youngsters have to take into account what they really want to do.
So,
So
like, if a clinician is like Madhuri madam, she will do the embryo transfer entirely. And if a clinician is like what I described just a while ago, then as an embryologist, I would like to do
yes,
the pushing.
and like in my center also, Randhir pushes the embryos, and he is so gentle and he's so meticulous about it that I have not changed my embryologist. So I don't have a choice also, but I have preferred not to change because it is economical, it is cost effective, and he will not run away. So now coming to cervical mucus cleaning. What is the best method to clean? Should you rub the cervix nicely? Should you clean with the culture media? Should you clean with saline? Should you aspirate? Should you use a cotton bud? So tell me your practice and what works best, and then Madhuri ma'am and Bindu ma'am will tell us what to
If
do.
it's just a ma'am slight drop of mucus, we can just dab it with a cotton swab, dripped in saline. Or if it is a large mucus plug is there, maybe we can aspirate and also flush with the culture medium. I always do that. Before the embryo transfer, I flush with the culture medium.
Flush from
I have a second opinion on this. Uh,
Sorry,
Flush with
ma'am.
I have a second opinion on this. I
Yeah.
generally don't prefer putting a culture media because I think that it pushes the infective this thing into the cavity, and I generally only use the cotton bud to just gently remove it superficially, and that's all.
How do you flush, Yukti? You put your syringe nozzle at the external nose or distance from it?
Distal from the external os, ma'am. Just and then
think
I
we
just
should
push the culture.
we should not flush it. According to me, first you clean it with saline. You insert your speculum. Again, you clean the cervix with saline. Depending on how much mucus is there, either you use a cotton bud or you use a syringe. And once you aspirate it, then you clean the cervix with the culture media. I don't think we should flush it because if you flush it many a times, even a small amount can go into the uterus and then there can be fluid in the uterus and this can then prevent implantation. So best is not to flush, but clean the cervix with the flushing media.
I also agree with Madhuri ma'am. I also do not flush the cervix. I clean it externally only as per what is the requirement. So try to minimally disturb whatever is there. So if there is a plug or something, it's goes away with the cotton bud, or at the most when you flush, then you just gently dab and the secretion is clear. I don't flush the cavity with the media.
No, I don't think so. Sometimes
The
flushing media is
cavity.
also required because just with your BD syringe, you can just aspirate the mucus out. And I think majority from what we have seen in all our embryo transfers, I think just purely aspirating with a BD syringe kind of tackles the entire thing. You don't need any more flushing or anything to be also kind of put into it to loosen it up or that's what if we are talking about. But just a BD syringe and just cleaning with saline, and once the mucus plug is separated, you can just wipe it out with a piece of gauze or cotton and it generally slides out pretty well.
So, most of us are not using any prophylactic antibiotics, of course, before embryo transfer. But studies have shown that if you use a prophylactic antibiotic, your culture tips are always sterile cultures. But at the same time, it does not cause any improvement in the pregnancy rate. So studies have shown that using a prophylactic antibiotic is not something which is evidence based or which will improve your results. Madhuri ma'am, any opinion about this?
Yeah, because I really don't do freeze-all. I do very few freeze-alls. And because when we are doing a fresh transfer anyway, I just give one injection of monoself. I really don't use antibiotics except if there is a patient of endometriosis. where I would give augmentin, that is amoxicillin with clavulanic acid, for 5 days. So anyway, it is covered when you're doing the embryo transfer. But when I'm doing a frozen embryo transfer, I really would not use an antibiotic.
So, ma'am, when we have used a shot of Monosep or ceftriaxone prior to our OPU, prior to oocyte retrieval
Not
under
prior. I mean, we do it when the anesthetist is there.
Yes,
So
ma'am.
we give a test dose, and the anesthetist, after the OPU is over, he will only give the Monosep.
Yes, ma'am. So a start dose. So you don't need any antibiotic after that till embryo transfer.
Except in cases of endometriosis.
Yeah, because you are
Yes, I would
scared that
definitely. Yes. I
But
would
as Madam
definitely
said,
give
it's the best practice to give after OPU is done, because once you have a reaction, I've had one reaction and the OPU gets completely fired.
Yeah, that's what now we give a
Test
test
dose
dose.
before OPU and antibiotic after OPU.
You are
Yeah,
giving
that's what you give a test dose and then
We
you
always
give
give a
after the
test
OPU.
dose, and usually within 1 hour of the pickup, we give the antibiotic. Home pickup.
within 1 hour. So Kanika and Rachna are giving antibiotic after test dose after the oocyte retrieval is over.
No, no,
Yes.
ma'am. Before the pickup starts,
No.
within 1 hour of the start of procedure, we give antibiotic.
Yeah.
And after
Rachna is
test dose, always.
I give test dose before, but antibiotic, the anesthetic, after the pickup is done, the anesthetic will start.
Yeah, the anesthetist only, it's always best to give the antibiotic, even though you've given the test dose. At times, we don't know, you can still get
Get
an
reaction.
allergy. So, therefore, it's best that once the pickup is done, then the anesthetist itself, whenever he's there, he gives the gives the entire dose. But the test dose is given before anesthesia is given, so that we know if anything is there, and then the anesthetist can accordingly treat.
So, anybody in your learning phase, did you touch the fundus and come back and do the transfer? Did you have difficulty in depositing the embryos at the site of maximum implantation potential? Does anyone have any idea about clinical touch technique? This was also used years back when ultrasound was not a uniform policy. So many senior IVF practitioners have simply done non-ultrasound guided embryo transfer, gone, touched the fundus, come back and deposited. I am sure Bindu ma'am must be knowing about it, and Madhuri ma'am also. So this technique was also used, but of course now studies and all these forest plot and all you have seen that ultrasound guided is the standard, and US GET or ultrasound guided embryo transfer is so much so the policy that now the latest studies are not even mentioning about clinical touch. They are not mentioning about transmyometrial embryo transfer. They are not mentioning transvaginal ultrasound guided embryo transfer. Any experience with transvaginal ultrasound guided embryo transfer anyone has?
Maybe in cases of retroverted
Yes.
uterus.
Have you done it, Yukti? Have you done it?
No, I have not done it, but I've just seen the videos and all in retroverted
Ma'am, I've
uterus.
done one case of this one transvaginal. So it's very difficult to do.
Yeah.
Easier than that is to actually counsel the patient that maybe we'll freeze and we'll try again tomorrow morning if you have that option, unless it's like totally hatched. But it's like very tedious. You'll have to put in first. What I usually do is I put the, by that time, I'm probably using the hard catheter. I put the catheter in, leave it over there, then introduce the transvaginal probe. And under that, you have to try to maneuver. Like Dr. Yukti rightly said, most commonly it is with these retroverted uterus only. I personally do not prefer to hold the cervix at any point of time because I feel like, and if I have to, in a rare occasion, that is where I would prefer to use atosiman. But yes, if you're using a hard catheter and if your bladder is properly filled, it's a rare, you hardly need this approach. It should never become the norm.
I
Uh,
have
So
also
basically,
used so sometimes in transabdominal, if we are not able to visualize the cervix and the pathway, so I have used the transvaginal, seen the pathway, and then after we get this, then shifted again to the transabdominal.
Actually,
no, I think
yes, ma'am.
according to me, like in these difficult cases, sometimes just using a stillet in the outer catheter helps you to negotiate the cervix into the internal os. And whichever of my case is difficult, I always call an ultrasonologist for an embryo transfer rather than my assistants or my nurse doing it, because they would really properly show you how to go into the cervix and then into the uterus. So all difficult embryo transfers, I think we should have a proper ultrasonologist rather than having your assistants or your sisters assist.
So the junior doctors and sisters who assist me, they have been assisting now for years, but
Yeah, but
still.
when it is difficult, it is not. But the position we only need to give them, and sometimes it changes, and they're not able to really show, especially when the direction of the cervix and the uterus is difficult, and it's a difficult embryo transfer where we've seen it was a difficult cannulation even at IUI or at hysteroscopy. So in these patients, you have to call an ultrasonologist who really shows you the cervix properly first and then the uterus, and that's the best method.
Ma'am, what about obese patients, ma'am? Like sometimes it becomes difficult in obese patients.
No, so all obese patients, I would call an ultrasonologist. They really show it properly.
So this is again a message that Madhuri ma'am has given, that see, with however hard you teach your staff, they will not see the uterus like you want to see it. They will just show you whatever they know. They are not radiologists, they are not sonologists, they are not gynecologists. So basically, when you want the best outcome, nobody else could do it better than a sonologist. The transvaginal ultrasound guided, there was a conference by Dr. Gautam Alabadia 15 or 18 years back, wherein they presented a series of about 50 or 100 cases, transvaginal guided ultrasound transfers. And this one of the authors was Sulbha Arora from Mumbai. So that got me very interested, that no full bladder, nothing. I came home and started doing it. But trust me, it is so messy. There is so much of, touching
Manipulation.
the catheter that it became a sort of tedious task. Same thing happened with sonosalpingography. SSG. I still find HSG is so much more convenient than an SSG, just because of the messiness, trying to track the bubbles, fluid, and all that. So, this is not a very apt comparison.
So even that, if you call an ultrasonologist and do it, is much better, because they also on the color Doppler, and with the color Doppler, they find out the flow, whether it's really going to the tubes or not. And that it's a much better way than me directly doing it. So if at all any patient I have who demands for an SSG, I'll always call an ultrasonologist. I will inject the dye, but I will have them, because they are more efficient in identifying really what is happening rather than me identifying what is happening.
True,
Yeah, I
madam.
agree with ma'am, because whenever I get an HSD, I have with a ultrasonologist only, because he even does a 3D immediately, and he gives me a very nice picture, and it's like day and night difference. Especially when you consider, you'll be able to rule out the false reports that you sometimes get, the corneal blocks in HSG. So SSG is really good for that. So, and if you have a radiologist, then icing on the cake.
So now questions for the ultrasound aficionados between all of you. There is actually, the studies say there is no association between the US system quality, the type of machine, the quality of machine, the probe, the ET outcomes. But do you think that when you do a 2D scan for an ultrasound, not for your OPUs, but for your ET, you should have a knowledge of the depth, the field of view, the angle, the zoom, the gain, the TGC, the contrast, the dynamic range. Would you like to adjust? And
And
would
with the
some
marriage, you have to know the machine in and out if you want the optimum view.
That's what, Rachna, I want somebody to tell me about the optimum settings. I don't want you to speak like a sonologist, but some insight into how these features. Why do the fetal medicine people say for NT the fetal thorax and head has to occupy 75% of the screen?
Yes,
Same thing applies to the uterus.
So I
absolutely.
think whatever your eyes are generally comfortable with doing, you have to understand the contrast. You need to understand the blacks and the whites and the grays. You need to make sure that the catheter is equally bright and not so bright. You need to also make sure that you increase the depth to such a level that the uterus is almost, I feel, almost maybe one fourth or one sixth of the vision of the screen, so that you're quite comfortable in seeing the entire cavity right from the fundus to the cervix. And I think there is no specific setting where you need to have that much gain or this much TGC, or you need to go left or right, or this much of zoom or depth which is required, but a condition which is optimal to suitable for your eyes. And probably that may be different for different individual. So even if we are seeing with different machines, different consultants working on a machine, the machine may keep on changing. The gains and the TGCs and the depths will change from people to people as to what suits their comfort zones,
So,
I
ma'am,
feel. So
using the depth and the zoom, the uterus in entity with the bladder should occupy three-fourths of the screen.
And
And
you,
then we can adjust the black and white 2D knob to see the differentiation so that we can see the catheter.
what should be the dynamic range? Should you keep dynamic range higher or lower, and why? You have any idea of the dynamic range, DR? So dynamic range is one very simple button on your 2D on your machines, all machines. If you turn it towards the right, the image becomes more contrasty, more granular. So it's very good for follicles. You will see very sharp follicular margins. But when you do the same thing, increase the dynamic range in your ultrasound for uterus, you will find a very, contrasting image. The endometrium will be very white, the myometrium will be very dark gray. So when you push your ET catheter inside, the catheter is also ecogenic and the endometrium is also ecogenic. So dynamic range has to be kept a little lower so the images become softer. So when the image on the screen is softer, the catheter shines very brightly. Now I want to ask Madhuri ma'am. Madhuri ma'am, are you in favor of using that ecogenic tip catheter, which is more costly? Does it work?
No, I mean, I don't use it because I feel whatever we are doing with the other catheters, it's easily seen. So I really don't use much of
So
ecogenic.
the message madam is giving that whatever catheter you introduce, and if your probe on the tummy of the patient is well placed with adequate amount of jelly, you will see the catheter. You don't need to have an ecogenic catheter or ecogenic eco tip catheter for which you are paying $1,000 extra. It is not required. If
So
it is
basically, even when you were talking about the size, basically you should have it first at the normal depth. You see, try to visualize the entire uterus and the cervix. Once you see the entire uterus and the cervix at whatever depth or the thing where you can really differentiate between the endometrium as well as the myometrium, then probably you just increase the magnification so that you can see it larger on your screen. So it also depends upon how big a screen you have, because many have a small screen, many have a big screen. So if you have a big screen and if you just magnify or zoom the image, once you've seen everything, you can really see it very well.
Yeah. So these are some technicalities of ultrasound which I think everyone should master. My passion is ultrasound, so I study every bit of it. But it doesn't mean we devote half our life to ultrasound. But now another very important question. Should you wheel in the machine from your OPD or ultrasound room to the OT to do your embryo transfer and OPU? Or should you have a dedicated machine for your OT and your ETs and everything? And what about a beginner who has just started an IVF center? Do they need to purchase two machines?
Machines dedicated for one machine should be dedicated for the
Yes.
OT, ma'am, which is for the OPUs and ETs. And the for follicle monitoring and all, there should be a separate machine in the OPD.
No, but if many people cannot afford in the beginning, what they can do is before they wheel in the machine into the OT, they have to clean it with alcohol, keep it outside the embryology lab and this thing at least for an hour, because you're cleaning it with alcohol, and then only take it into the OT. That's just what it is. But having two machines is one of the best things what everybody should have. And I think you should have two machines because one you should have as a backup. But many a times it's not
Mm.
possible for everybody to buy because today the machines are so expensive. They're more than 30 lakhs a machine. So many a times it might not be possible for people. So in those cases, this is the method which you could use.
This is a very good message that you can clean your machine with alcohol. Anyway, your machine is going to be clean. You are not doing a whole lot of ultrasounds like radiologists. You are doing your fertility patients, you're doing your obstetric patients or whatever. So you can wheel in your machine after cleaning it properly with alcohol and allow it to be outside in the chamber outside or the place outside your actual OT for an hour or so that the fumes evaporate, and then put it inside your OT, or maybe one night before. You do your OPUs and ETs in the morning, the evening before you can do this procedure. So that's a very
Legally, it won't be a
Ma'am,
problem
I had a
moving the
question with
ultrasound
regards to
machines from
PCP and
here to
DT.
there.
NDT
Legally,
also they don't
is it
allow
not a
moving.
problem?
Yeah.
as
We should not move the
NDT as
ultrasound machines from here to there.
one
We are
second.
not
The
allowed.
ultrasound machine is on the nursing home license. Legally, there is no problem. You can move the machine in the
As long as
premises
you
which you are
have
taking
all your
permission.
PCPNDT things put wherever it is, you can move your machine as long as it is in the same premises.
In the same
So when we do a PCPNDT registration, there is always a area dedicated or area located wherein you can
Yes.
actually map out the
Exactly.
area
So
and
different
put where the
municipal
machines
corporations,
are.
they
But
enforce
you
it in
can
different
actually
ways.
plot out that area where your machine will be transferred and moved. So
You have to take
theoretically, you
prior
can actually
permission for
mobilize it.
yes.
What
Yeah,
if it
but
is
then
on
you're
the
right.
on different
Because
floors? What
especially
if
for
it is on
ART
different
clinics,
floors?
they have this clause which is put up over there, and they say that you can, because they know for ART clinics you require an ultrasound machine. So all people cannot, as I said, cannot afford two machines. I have two machines. That doesn't mean that everybody has two machines. So you can always read because that clause is there. At least in Karnataka, they have that clause.
Even on different floors, you can move. If the license is a nursing home license and PCPNDT is again in the name of the nursing home license, which is covering all the floors, it can be moved.
Yes.
So you can, I have a friend whose OPD is in the ground floor and her IVF lab is on the fourth floor of a hospital. So they moved the machine by lift, and in the process of moving the machine, the staff damaged one of the TV probes. It was a Samsung machine, a new machine. So luckily it was just, at the fag end of the warranty and the probe was covered. But so this shifting might be a little, you have to be
No,
very
but I
careful.
think it's best only if it's on the same floor.
Same
If it's
floor.
not on the same floor, I think you should have another machine because just shifting from one floor to the other and all, you cannot really guarantee our staff doing all those things.
And madam, nowadays we have got economical machines like GE has got the Varsana series, and many like smaller machines are like around the range of 10 to 15 lakhs with Dopplers, which you can easily put in your OT and have. Now, anybody is using 3D rendering of the image during embryo transfer and after embryo transfer? Anybody has used this?
No, I'm not used, but I saw Madhuri ma'am's lecture today, so I'm just dying to try that tomorrow.
Yes.
For that, I'll have to wheel my machine because my ultrasound machine in the OT does not have 3D, means it does not have that probe. So
So,
I'll rather get in this one and I'll definitely use it. And I would like to update also regarding that.
no,
It'll be
so
really
whenever
nice.
whenever my ultrasonologist, because I cannot tell my staff to do it, but whenever my sonologist comes for the embryo transfer, after we use a 2D for the embryo transfer, but once it is over, she would put a 3D and check exactly where it is.
Ma'am, how
Ma'am, right now there's a live option also, no, in all the 3Ds available because there's 4D
Yes,
in it.
yeah, it is
So can
available.
we,
But
is that
ma'am,
means
can
have you
you
tried it with the
can
4D
you
no,
tell
means live?
I've not tried it.
Okay, okay.
Ma'am, studies have shown that they have all same pregnancy rate, whether it is 2D,
Yeah, yeah,
3D,
I said
4D.
it. I said
But
that in my talk.
3D will help us, the precision is increased and that we can identify the point of maximum implantation potential and all. So,
Visualization is better.
visualization is better.
As I showed in
Precision
my
is
talk, it is 20% against 40%. That's it.
As
Yeah.
ma'am was mentioning, Monica ma'am, the maximum implantation potential. So that can be identified with 3D.
And actually, the shifting of the embryos can be studied. Suppose you're doing a research, you're doing a study on how much, or you're studying your own data with your embryologist, that how much is the embryo bubble shifting after 60 minutes or something. You can use, usually, you can use this rendered image and do it beautifully. And nowadays, the machines are so good, you even ask the patient to pass urine. You put a probe. If the bladder is minimally full, also, you will get a good uterine cavity, and a 3D you can do. Or you can do a TBS after. Madam, Badri ma'am, can we do a transvaginal ultrasound to see the embryo bubble after embryo transfer?
No, it's best not to, touch the cervix because that's again going to induce endometrial peristalsis and myometrial contractions. So that can expel the embryo. So I think we should not do anything transvaginal.
Sure. So here, this is a study 5 years back, 2000, where 3D, 4D ultrasound have got 80% accuracy of embryo positioning. So this is it. Catheter selection, you have to see now which, just like all panelists would give me the input of the type of catheters they are using. Do they go for softness? Do they go for economy? Do they do it patient-wise? Do they give the patient the choice of catheter? What do you do?
Soft catheters, ma'am.
Soft
I
catheter.
prefer soft catheters. In case of difficult embryo transfers or cervical stenosis, maybe with a stillet, maybe I use it sometimes. But I use soft
Soft
catheters.
catheter. Same.
But if you see the Cook's catheter has the outer catheter has a small bulb at the tip,
It's
and
got a
it
bulb.
really is more atraumatic when you're putting it inside, and it gives you a better positioning according to me. So I've used quite a number of them, and I have come to a conclusion that the Cook's jet catheter is the best because, and it also has a stopper so that you know the cervical length, so you can adjust the stopper to that cervical length so it does not go into the uterus, and then you can just put the inner catheter, or if you're doing a preloading, it's both together.
So, panelists, would you like to tell me what is the use of the bulb at the tip of the catheter? Why is the bulb so useful and makes things so easy? Can you tell me the cervical canal anatomy and how does the bulb help? Anybody? I just read about it in the morning, so I'm very excited about it. The
Now,
bulb.
many times when uh, yeah, many times it helps to guide you at the os. When you reach it, right, you have that feeling. So whether you go into the cavity or external. So what I usually do is I just stay just ahead of it.
No,
So it helps me.
what is the typical characteristic? You do hysteroscopies day in, day out. What is the typical feature of a cervical canal? It is the crypts.
Crypts, yeah.
Crypts.
Yeah,
So
so you don't touch them and sort of scrape them.
the bulb just
Yeah, it
bypasses
just bypasses it. Yes, yes.
right through till you reach the internal os. And internal os is like the gateway to the uterus.
Yes.
किसी के भी घर जाने से पहले आप दरवाजे पे रुकते हो. You don't barge inside. So this is the point where you stay. The bulb will slowly, enter the internal os, and there will be no trauma at all to the cervical canal or the crypts. That is the beauty of the bulb. So I totally agree, and I also use a catheter with a tiny bulb, which really helps. And the bulb sometimes may be spherical, it might be slightly oval, and it is absolutely atraumatic. So we have already talked about the no need for an ecogenic tip or an ecogenic catheter. Please don't go by those marketing gimmicks. Madam, any experience with the opening of at the tip of the catheter or opening at the side of the catheter? Does it happen in embryo transfer catheters also? IUI catheters have the side opening.
No, so this has only a opening at the top. Most of
Yeah. So
Now people have started using the India-made catheters also. So we all swear Cooks, but then now the Krishko is also coming up. It also has a bulb at the tip. So qualitatively, it may
I don't
not look
prefer
as
using.
good as Cooks, but it is giving results.
No, but what I don't prefer using much of the Indian ones because we're not sure of the mouse embryo toxicity testing which has been
So
done.
that has
with
been done. At
catheters.
least for this that I'm saying Krishko, they have done that.
I
But
mean,
again, as I said, qualitatively, the look is not as good as Cook's, but then it is giving results. I have used at one of the clinics. They use Krishko, and it has given us good results as well. So
Bindu madam, would you tell us a little bit about catheter loading? We have all these options. Air, embryo, air, medium air, embryo air, medium. So what, this is very confusing. What do you actually do?
So the thing is, I have come from both the generations where we did not do any ultrasound guided transfer and we did not do any loading air, media, air loading. No sandwich method was used initially. We just loaded with the medium and we transferred. So whether it is ultrasound guided, no sandwich method, or now because we are doing ultrasound guided transfers, it becomes easier to visualize if we do a sandwich method of loading. That means you have the medium, air, then the medium containing the embryos, air, and again medium. So that means you have the embryo sandwiched between two columns of air, and then the medium, of course. So this sandwich method makes it easier for you to visualize the placement of the embryos within the cavity. So that is what what this figure is all about. Medium, air, medium with embryo, air and medium. So that's how you load it. So what you do is the inner catheter, you have, because you are flushing it with the medium. So medium is already there. Then just slightly pull the tip, pull the piston so that you have that cavity of air. Then you load the embryo. Again, you fill it with air, and then again the medium. And that is how then you take it for transfer. So that is the sandwich method of loading the embryos. It helps in visualization.
Madam,
And the
doesn't
last one that you see is just the one that we initially followed. The C, figure number C, is medium with embryo, and we just loaded and transferred.
so the sandwich method, Bindu ma'am, doesn't it increase the microliters of total media?
No. So the thing is,
Yeah, so this is
all
this is
recommendations.
3, 3, 5, 1 and 1.
Yeah, so recommendations suggest that 10 to 30 microliters, right? So if we are doing just with the medium, even a 10 to 15 microliters is enough. But if you're doing the sandwich method, you need at least 30. I go up till 35 as well. So 35 microliters is my standard. I don't go beyond that. But if I do a sandwich method, it is 30 to 35 microliters.
So which is the best method, Bindu ma'am, according to everyone?
No, so best method now, like I said, because we are doing ultrasound guided, it becomes easier to visualize if there are air bubbles.
Okay.
So the volume, as long as you stick to the volume, you are not overdoing it. We are not going to load with 50 microliters or 40, 50 microliters. So that is fine. Up till 35 microliters is absolutely fine.
So loading with these 5 layers, is it more tedious and time consuming as compared to a simple air, medium, air?
No.
No, with practice, it is easy.
Okay, madam. Right. So just I wanted some clarification on all the different methods, which was something new for all of us. This madam has already told us about. Any other doubts? This was a very sort of, practical sort of panel where I wanted to just ask you about what you all think. So if there's any other doubt, we are already close to 8:30. You can ask. Otherwise, we can close the panel and call it a day, call it a
I have a
night.
question for Madhuri, ma'am.
Yes, please, Renoy.
Ma'am, have you ever encountered means like when you have sometimes even after you've done a hysteroscopy in the prior cycle or whatever, maybe you'd have done a dilatation also, which is hardly done because of office hysteroscopes nowadays. So suppose you're going ahead with your Cook catheter and you find like you are there at the os, it's a straight canal, and you have this very tight os, and even your soft Cook catheter is not going through. So what do you use? Do you use like you maybe push it slightly, or you use some screwing movement, or do you just like if you want to, you're not just
I use a stillet in the outer catheter.
okay. Yeah, because that will actually help it go through.
Yes.
Otherwise, sometimes
And the
I've
stillets
tried
are
using
also
atosiban, it doesn't help.
no, the stillets are also very soft. They're not very hard.
Very hard, correct.
Yeah, so they are very soft stillets, so that really helps.
Okay.
Madam, do you keep the catheter for a few seconds at the site of transferring, or do you withdraw immediately?
I withdraw immediately.
Immediately, right. I think everyone must be checking the catheter for retained embryos.
Yes.
Yes.
Madhuri ma'am, I have a doubt. What's your take on endometrial scratching?
I don't do.
Ma'am, whether you withdraw the inner and outer together or inner inside and then withdraw the whole assembly?
No, I withdraw it together.
So inner is outside and outer is here when you withdraw.
Yes.
Same here. I also do that. I just like after transferring, I don't withdraw the inner inside the outer.
No, because what happens is if you're pulling the inner catheter into the outer catheter, many times that suction force also is there, which might just, displace your embryo. So it's best not to pull in the inner catheter into the outer catheter. So I just remove it just like that. At least I do it that.
Dr. Rachna, you are creating unnecessary shearing force and suction. That inner going inside the outer, and suppose the embryo also gets pulled inside, I mean, that's just like, so try to just remove the whole assembly out. That is what.
Just for
As
the
long as
Madhuri
your
ma'am,
embryos
you
don't
explained-
regurgitate, that's fine, probably.
though it said that rest is actually not recommended, and most of us say no rest, but considering the road scenarios which India is most of the time suffering, do you actually tell your patient to not travel much? Not
Ah,
home rest, but travel.
so I did
Avoid
not prepare.
exertion.
Rachna,
Avoid exertion, I think.
I prepared a YouTube video about travel for some of my patients because many of the patients were traveling. There was a very interesting study which was carried out in Brazil, and Brazil has got a lot of medical tourism in South America. So they compared the patients who traveled immediately after transfer vis-a-vis the local patients. And this traveling was by road, by bus, by flight, everything. And they found the pregnancy rate higher in those who traveled because they were so busy in the travel and planning and taking a trip that they did not bother about anything. And the people who were, went home and laid down on the bed and wo restriction, they had a lower pregnancy rate, but it did not reach significance.
I think just half an hour of rest is more than enough.
Okay.
30
And
minutes.
also one question. So if your embryo has become a blastocyst on day 6, do you transfer at 120 hours or on days 0 plus 5 we transfer a blastocyst? But
No,
if
so
that blastocyst is a slow growing
what
one.
happens is it's been said that it depends upon uh, when you've started your progesterone injection also after your oocyte pickup, and if your blastocyst has expanded on day 6, that is also in the afternoon or after that, then it's best to freeze it and then do it in a subsequent cycle, because the window of implantation then will not be optimal if you do a day 6 transfer.
So day 6 embryo freeze and transfer at 120 hours in the next cycle on day 5.
Yes.
So it depends on the stage of the blastocyst also. If you are talking of a expanded blastocyst, it should be day 5, that is 120. Then it is 0 plus 6. I mean, the 6th
0
day.
plus 5.
0 plus 5, sorry. 0 plus 5. But if it is a hatched blastocyst or a hatching blastocyst, day 6, day 7, I mean, a normal development also, a day 6 blastocyst, which is hatching or completely hatched, then you can do likewise. So then you will, then it will be 0 plus 6 if it is a hatching or hatched. If it has formed on day 6 or day 7.
Bindu,
Ma'am, I had a question for both
I'm
doctor.
sorry, let me clarify.
Yeah, okay.
If you have an expanded blastocyst that has formed on day 6, then you will consider, while doing an FET, you will consider as a day 5 blastocyst only.
Yeah. No. When you are doing an FET, whatever blastocysts are there, you consider them as day 5 and you transfer it on day 5 in a FET cycle. I prefer doing my FETs in a natural cycle or a ovulation induction cycle. When I use a ovulation induction cycle, I prefer tamoxifen because it gives a good endometrium rather than letrozole. And the pregnancy rates I have found is much better. And that only I use only in patients with PCOS. Otherwise, I do a true natural cycle. I don't even do a modified natural cycle. Once the follicle is about 16 millimeters, 15 to 16 millimeters, I do the LH and E2 level, identify the LH surge, and identify that the follicle is ruptured, and I do scans every day. So I know which day the follicle is ruptured, and I would count that as day 0, and then I would do the embryo transfer on day 5.
Ma'am,
Ma'am, I had
this
a
Bindu
question.
ma'am.
Yeah.
Sorry.
Yeah,
Bindu ma'am,
there's
this
this
sandwich.
Acha, okay, you go ahead. Fine.
Oh, I'm so sorry. This sandwich technique is associated with better pregnancy rate also,
No,
anything
no,
like
it
that,
is
or just
no
visualization?
visualization.
Only visualization. Okay,
It
thank
is
you.
only for the sake of visualization, and it becomes easier, as Dr. Monica said, if the patient is seeing on screen, it becomes very relaxing for the patient also to see कि ये देखो 2 drops दिख रहे हैं, shine कर रहे हैं, उसके बीच में आपका embryo है. So it becomes easier for visualization and to show to the patient as well.
Thank you.
Bindu ma'am, you have presented in Ashri the transfer of hatching blastocysts, if I remember correctly.
Yes.
So how did you manage to do that? Hatching blastocysts, how did you transfer?
No, because we can do the normal way only. There's nothing.
That is the same way.
We do many a times hatching blastocyst or a hatched blastocyst.
Yeah, because that was the time when assisted hatching had just come in, and we thought that rather than subjecting the blastocyst to some chemical or a laser, it would be better to allow it to hatch naturally. So spontaneous hatching versus assisted hatching, that was our paper all about. So yes, we still prefer natural spontaneous hatching. if at all we are transferring that?
No, so yeah, so basically what I feel is assisted hatching should be done only when you feel that the zona is not thinned out, especially when you're doing a frozen embryo transfer. I think only that group is a patient wherein you do assisted hatching with a laser. Otherwise, in most cases, at least, because if I'm going to do an embryo transfer today morning, because we normally do all our cases at 7:38 in the morning. So the previous evening we thought the embryo, so we know that they have expanded also. And many a times, if you see them next day in the morning, they are already hatching also. So basically, it's more. I mean, at least we thaw them 12 hours before our embryo transfer. That is what we do.
So you
Ma'am, I had a
time
question.
your, I mean, 120 hours or 130, whatever, 120 to 144, depending on what is the stage of your blastocyst. And assisted hatching also, it is now no one really does.
But more than Bindu, more
Scaling
than
of your
that, you
zona.
should also look at the timing you have started your progesterone.
Correct.
So your development of your endometrium will depend upon what time the progesterone has started. So the
You have to
hours
time
will
your
come.
progesterone as well as your stage of blastocyst, the timing.
Yeah,
So,
especially when you're doing a frozen embryo transfer. When you're doing a fresh transfer anyway, it is the hours really
yes.
are whatever you were saying.
So, Dr. Rachna, I would like to come to your question. You were so, like Madam said, Madhuri ma'am said, we always prefer the day 6 embryo. Also, we prefer at 120 hours. So, I totally agree to that. Also, we have to see the history also in such cases. If the patient has multiple IVF failures or recurrent miscarriages, so I had a patient with 5 failures and they had used embryo donation in both all those 5 cases. So, ERA is of very limited use. We only use in RIF or multiple miscarriage. So sorry, the one who has never conceived, primarily with who has never come positive. So one of my patients showed implantation at 144 hours according to ERA, and in the 6th embryo transfer they actually conceived. So in those cases, we can go for a as per
Yeah,
the ERA.
ERA is separate. I was just talking about routine when we're not doing ERA.
No, no. So routine, if it is on day 6, it's just a 4AA, then it is better that you freeze it and transfer it in a subsequent cycle.
So I think we have had a very, very fruitful and healthy discussion, and all the embryos have turned into blastocysts. We are ready to, start practicing tomorrow all these good clinical and lab points we have listened from stalwarts. So these are the 12 factors associated with ET success, which are there as evidence. Removal of hydrosalpinx, ultrasound details of uterine cavity and ultrasound guided transfer, doing a good mock transfer one cycle before, ultrasound guided transfer, cleaning or removing the cervical mucus plug, avoiding the use of Alice and tenaculum, using a soft catheter, avoid blood on catheter tip, do not touch the fundus, keeping a catheter stationary for a couple of seconds. Nobody has got now 1 minute to wait. 30 minutes rest after transfer max, and giving antiprostaglandins if needed to prevent contraction. Madam has talked about piroxicam. So these are the factors, and wishing you all a very, very fruitful 2026. May all your patients turn into positive, singleton, live, healthy pregnancies. And may you all get 2 and 3 ultrasound machines. May you keep learning, growing, and doing good work. And please remember, whenever you do good work, share your knowledge, because knowledge shared is knowledge doubled.
Yes, yes, Dr. Monica, very well, and we are very entitled. Madhuri madam, मुझे पहली बार पता चला कि you are a very good embryologist also, because I was thinking that you are a best clinician, but आज सुनने के बाद embryo transfer के बाद
सर
मैडम
तो सर एकदम गेस्ट अपीयरेंस पहले और आखिरी में आके अपना
नहीं, मैं पूरा
चक्के
सुनता हूँ,
मारते
मैं
जा
पूरा
रहे
सुनता हूँ, तभी तो
हैं।
मैंने कहा ना बिंदु मैडम, जहां जहां लगता है मेरे को। और आपका एक्चुअली जो पेपर था चिमोड़े सर ने बनाया था, जो इट वाज सेंट टू एशरे, इट वाज टोटल ऑफ हैचिंग ब्लास्ट। बट मैडम माधुरी मैम, अभी जो रिसेंटली मैंने एशरे और आई हैव गॉन टू द एसआरएम, जैसे हमारा पहले था डॉक्टर बिंदु मैम कि डे 5 ही ठीक था, डे 6 पे क्वेश्चन मार्क था। बट माधुरी मैम एंड बिंदु मैम, यू कैन गिव यू विथ योर एक्सपीरियंस। I am also, but I'll not say that my day 6 are better than day 5, but day 6 are not
very bad
Yes,
has
of
day
course we
5.
can transfer. Of course we can transfer
See,
day
I
5,
want
day 6,
your
day 7.
experience क्योंकि क्या होता है मैडम sometimes you wait and then कोई you are absent या patient नहीं है कुछ भी मैडम हम day 6 तक ले जाते हैं तो
Yes.
just I want a quick answer from both of you or anybody experience. Does day 6
See,
are bad?
any embryo like which is a good quality. So if it's a 3A also we would do a day 5 transfer. But suppose it's grade 1 or 2 only on day 5, then we would not do an embryo transfer for this. We would culture it till day 7. If they become a good blastocyst on day 7, we will still freeze them and then do a FET in the subsequent cycle.
Yes, yes. They may not have the same implantation potential as an expanded blastocyst on day 5, but they are definitely, I mean, they can give you a pregnancy and good quality day 6, day 7 blastocyst. We do get pregnancies out of it.
Okay, so Madhuri ma'am, you have given me one question for my study. Monica, note down. We'll give this job to PGs. So you are considering day 6, day 7 inferior implantation. That means soil is bad, seed is good because the implantation window of the uterus ends by day 5. No, ma'am, Madhuri ma'am.
Yes.
Okay, okay. Yeah. So इसका हम study बनाएंगे मैडम and we'll present after 1 or 2 years. Good,
नहीं
good,
सर,
good thought.
सर implantation window close होती है वैसा नहीं है.
The synchrony, the endometrial embryo synchrony is lost.
No, ma'am. No, ma'am. I would say is lost only if it is not an expanded blastocyst on day 5.
That is what I'm trying to tell you. If it is a grade 1 or 2 blastocysts on day 5, it is better to take them to day 6 or 7. If they become a good expanded blastocyst, then you freeze them.
Yes. But Ranveer
But
sir,
if it is an expanded blastocyst, you can do on day 5. It doesn't make a difference.
So, or vice versa, ma'am, Madhuri ma'am, vice versa, we can freeze all the not up to the mark, day 5, freeze karo, madam, or next cycle में FET में grow करिए, and if you think after 1 or 2 day growth, they become a good blast.
हाँ, वैसे भी कर सकते हैं, हम वैसे भी करते हैं lab
Yes,
में.
ma'am, yes, ma'am, that's good.
So
good,
if
good,
you are
good.
saying कि fresh transfer करना है आपको और day 6 पे hatching blastocyst है, that is not out of sync. Day 6 hatching is good
नहीं,
enough.
that is वही मेरे को याद है चिमोटे सर का you have presented this paper in the I think Munich ESHRE and so it was a unique and first time. So I think Madhuri ma'am अब एक debate का question है कि where our implantation window ends.
Actually, it is different for different people, but it is basically on day 5, and it also depends upon when you are starting your progesterone level. Because when you are given, especially both in a fresh and a frozen cycle, but more so in a frozen cycle, because it will depend. Suppose you're going to do on day 5 and you start your progesterone in the evening, then it really you have to probably do it on day 6 and not on day 5 because your window is going to be a little later. But in a fresh embryo transfer also, they have said that it really does not make a difference whether you start progesterone on the same day of oocyte retrieval or after 2 days. There are studies, but I normally would start. So if I do an oocyte retrieval at 7:30 in the morning, we discharge the patient by 11:30, and at that point of time, we start the progesterone. So basically, then we do the day 5, we do a day 5 transfer. And it basically will also depend upon suppose on day 5 in the morning, because normally we do most of our cases around 7:38. But on day 5 in the morning, if we find that it is just a grade 2 or 3, then we wait till evening and we would do a transfer in the evening.
Yeah, perfect, man. That's
so
good.
It is more about the hours of development rather than day. I just have one thing I just came, if I have the time to say and ask, since Madhuri madam is here, just 2 days back we had a clinical meet and one clinician suggested that it's not about a difficult transfer, a patient who is extremely anxious and who is just not ready to let you insert the catheter. So what she does is, she said that a few drops of xylocaine she puts in her mouth, asks her not to gulp it, just below the tongue, and she relaxes and she does easily the embryo transfer easily. So this is something different and new.
I have no idea about this.
Not to do such things.
Yes, I think it can cause so many side effects.
Reactions and all.
Yeah, so I would prefer them doing it under general
reactions.
anesthesia rather than doing it just requires a short GA. But many of my patients, I really counsel them and I tell them that nothing will happen. And in many patients, it has worked.
Yeah, so this was not about a difficult transfer.
I
It
know,
was
that's
just
what I'm saying.
yeah.
Yeah,
But I
so there
looked
are
up
some
and there
patients
was
with
no
contrast.
evidence, no such evidence,
No.
but this clinician said that she does it and the patient just relaxes and it is easy to do
How
the
can a
transfer.
patient relax with xylocaine in the mouth, yeah?
I don't think,
know,
yeah,
I don't
it
know.
can be a placebo. Madhuri ma'am, it can be a placebo.
Yeah,
It can
yeah,
be a
At least she
placebo.
doesn't speak.
But I think, but Bindu
And
ma'am,
then
this
she just asks her to, I
Mm.
mean, throw it off after the transfer. It is not.
No, I think it will
It's
act
not
as a
allowed to
placebo,
gulp
and
it.
I
How is
think
it going to act, yeah? I don't know. At least according to me, that pharmacokinetics doesn't work in that way.
no, ma'am, it will not work. It's mainly basically placebo. But one thing, this point has Monica, if you remember, one medico thi, madam. One I think she was an obstetrics gynecologist. We were doing the IVF, and embryo transfer बहुत difficult था. So she asked, please sir, do under GA. So I told you search in the Google world में कहीं भी embryo transfer, if it has been done under GA, you let me know. So that made her
Yeah,
confidence. Mona, याद है ना? She was a
no,
gynecologist, I think so. Na?
no, embryo transfers are done under short GA, and the studies have been there, and the results have also been obtained.
Yeah.
There are some.
It
We have
doesn't
also
affect a
done
short
in
GA,
some
really does
selected
not
cases.
affect the embryo transfer results.
We have done cases in GA and we've got
It
results.
is done. It is done. So
Not
that
locally.
that brings us to the end of this panel discussion. I think we have got lots and lots of questions still remaining. We will have a part two. And evidence is all about what literature says and what is the general consensus. At the same time, there are certain idiosyncrasies which people follow, but they should not be given as a public message, like the
Yeah,
xylocaine.
No.
It should
yeah, yeah.
be cannot be spread as a message. Humbly requesting for your vote and support. All of you are proud Isarians. Please support Dr. Randhir Singh for Managing Committee Member, Embryology, and myself, your host and convener, Dr. Monica Singh, for Managing Committee Member, Clinician in the forthcoming ISAR elections. We will be very honored to continue serving ISAR.
Best wishes to both of you, ma'am. Best
Thank
wishes.
you.
Best
Thank
wishes.
you.
Best
All the
Thank you.
wishes.
best.
Best of luck, ma'am and sir.
And thank you, ma'am,
And thank you,
For
Madhuri ma'am
so
and
much,
Bindu ma'am.
thank
for
you
a
for giving us the opportunity.
very
Thank you.
comprehensive panel. And as a last note, if I might say, one of the MOC said Dr. Madhuri Chimote, and I can never be like Dr. Madhuri Patil. Whenever the names they got, she said Dr. Madhuri Chimote, and it made me feel happy. So
Yeah.
yes, thank you
Very
so
good.
much.
Thank you, ma'am.
Thank you
Thank you,
so
ma'am.
much, ma'am,
Thank you,
for
Madhuri,
making up
ma'am. Thank you,
making me a
Madhuri, ma'am.
part again. Thank you, ma'am.
Thank you.
And
Madhuri, ma'am,
everyone
we
and
are
best
waiting.
wishes.
Madhuri, ma'am, we are waiting. जब आप president बनेंगे 2 years, I think the Cochrane will attract to India only.
We are there. We are there.
सोचना
Yes,
पड़ेगा ना
yes.
सच्ची में प्रेसिडेंट बनना है कि नहीं है इतना
अरे
Yeah,
नहीं.
ma'am. If not you, then who?
Yeah, ma'am.
Because I'm
Thank you.
I'm a very straightforward person. मैं ऐसा किसी के पीछे पीछे नहीं बात करती हूँ मैं तो सीधा मुंह पे बात करती हूँ
नहीं,
We
madam,
need
I
people.
remember.
We need people
नहीं,
like
madam, I
that,
remember
ma'am.
your thing. Madam, I remember your thing. My Bhopal conference. Actually, Bhopal is a small city, and all the rooms were taken by the pharma companies. Madam scolded Randhir. In my history of 30-40 years, I have never gone with any pharma.
No,
Madam, याद है, ma'am?
I don't take a pen also from them.
Yeah. So then I took जो मेरे पास room थे personal, myself and Monica. I gave my one room to Kundan Ingle and one Monica's room you were taken, ma'am. So I think, madam, we respect you, ma'am, your knowledge
No, that
and
is
your
why
experience.
you won't believe it. I have gone and booked all the hotels. As means I had gone and spoken to everybody even before we bid for the conference. And after we bid, we went and finalized everything. Though now Madam is not giving her dates or whatever it is, that is a different issue. But I had paid for a 5,000 room. I paid 22,000 per day in
मैडम यही
Lucknow.
होता है ना मैडम देखिए बिल्कुल जैसे बेंगलोर को
Which I don't
बेंगलोर को
want, which I don't want to happen. So whatever
But,
rate they are getting, we want to give people the room at the same rate.
नो मैम इट्स मैडम क्या होता है जैसे फॉर एग्जांपल मैं तो मैडम आई लिव इन द भास्कर यहाँ पे द मेरिट बिलोंग्स टू माय कॉलोनी पीपल मैडम जैसे ही कॉन्फ्रेंस का रेट होता है मैडम दे डबल एंड ट्रिपल द रेट होटल वाले बोलते हैं हम तो इसी
मैं
सीजन में
सारे
कमाएंगे
होटल मेरे जो 5 और मैं सबके साथ बार्गेन करके आई हैव लॉट ऑफ कॉन्टैक्ट्स ओके दे आर जस्ट बिकॉज ऑफ माय कॉन्फ्रेंसेस आई ऑर्गेनाइज एंड एवरीथिंग आई हैव गॉन एंड बार्गेन फॉर द main conference. I have reduced by 2.2 crores total for 2,200 people, 3 lunches, 2 dinners, and one more smaller dinner for the faculty on Thursday, and 300 rooms. Everything उन्होंने जितना भी दिया था, I have reduced it by 2.2 crores. And
That's great, man.
and I have some people who are in the other hotels also. So I called that person online on the Zoom and I made him talk to that person who's dealing wherever we are doing the conference. And he also helped me in reducing quite a bit. That's how it works.
No, ma'am, we are very
good,
great,
sir.
ma'am. So therefore, I'm thinking, man, your presidential for 2 years, it will be great for us. And I think all this
No,
scientific
and
will
then in
continue.
this conference, I'm doing all the work, but I don't want
Yes.
any post. I'm
Yeah,
without
yeah.
a post.
Yeah,
Sir,
yeah. Thank you, ma'am.
we want a special discussion on this topic
Yeah,
because
yeah.
there was one person who asked me, अगर फार्मा वाले स्पॉन्सर नहीं करते तो कितने लोग कॉन्फ्रेंस में 18,000 भर के जाएंगे?
तो मैं हमेशा सारे
Very
conference में
important.
करती हूँ.
I mean, 18-20,000.
Ma'am, presently the national conferences are having lesser attendance and focused conferences who are making you pay but giving you the knowledge and sharing proper knowledge and time. People are paying and attending the entire conference.
And that is the reason why you have so many registrations, but then no one in the halls, because then they don't take it seriously.
No, because they're
Pharma
not
has done the registrations and
Because
people
they're
don't
not
turn up.
Now you tell me when, now I went for this IFS, okay? So you're traveling from here to there is 25,000. Staying there is another 30,000. Plus you pay whatever the registration fee is. So when I was there in the ISA session, so we had about 40 people in that room. Then we had a FPSI session, okay? And then one speaker didn't come, so last minute I gave a talk. There was only one person in the hall because that hall was somewhere in the corner. So what I think is that you should not have that many halls. Everybody wants to come as a faculty, which should not be given. Only those people who have good knowledge should be given a lecture. And you should have lesser number of halls so that you have people attending. That is my principle. Now also I've made a program and I've given Ahmedabad. But what they do with the program, that is their issue. But I have done a full program and I have given them both for the workshop as well as for the halls. But
absolutely agree, ma'am.
I have seen and I had given 15 minutes discussion after every session, which is the most important thing. Because without discussion, it really does not make any difference for this thing. Like in all our PCO Society conferences, we have half an hour discussion after every session.
So then in that sense, these webinars are better. And not to say against any particular society, but then everyone makes, everyone wants to be a faculty, then you increase the number of registrations and there are no listeners. So what is the point? So, just make any Tom, Dick and Harry faculty. Yes.
That's the problem.
And exorbitant rates. And see, ma'am, for us embryologists, we don't even have any sponsors. Every conference we
But
go,
I also
money
don't
from
take
our own
any
pocket.
sponsors. No? I also don't take any sponsors.
Yes.
I don't
And
take a pen also from anybody.
People call us fools कि अपना रिसर्च भी खुद के पैसे से करते हो, एशरे में भी खुद के पैसे से जाते हो और लोकल कॉन्फ्रेंस भी खुद करते हो. So that is how it is. I mean, but it's a vicious circle that we have got into. We need
नहीं, Dr.
something
Bindu और क्या
drastically
अब
about it.
MCI norms आ गए हैं तो now we are going with that and I think Dr. Monica ये बहुत endless topic है, we
ऐसा
can
कुछ
now
नहीं है ना.
wind up.
अभी तो सब लोग वैसे भी स्पॉन्सर करते हैं, तो वो लोग क्या करते हैं, instead of paying directly as a delegate fee, they are paying it along with your sponsorship amount. So the sponsorship amount includes the registration also for people.
Yeah, ma'am. That's good.
I don't believe only in all these things.
Yeah,
I'm
I know.
associated with so many international organizations. ऐसा कुछ भी नहीं होता है. Now, if you
नहीं,
go
नहीं.
for the AEPCO society, 50 लोग होंगे तो भी ठीक है, पर
Yes, ma'am.
have to
We'll
be
go it.
proper.
Yeah. इसको पढ़ना है मैडम. The student who want to learn, they will come. Yeah.
So that.
Okay, I think Monica, we can wind up.
Yeah. That brings us to the end of the webinar. Thank you everyone for a very enthusiastic participation.
Thank you, ma'am.
Madhuri ma'am is the star of the show. And Bindu, you also have been a star of the show. Thank you so much.
No. I mean, you can't say that with Madhuri madam there. So much. What a learning experience.
Thank you.
Bye.
Thank you so much, team. Thank you, everyone. Bindu ma'am, you have
Oh,
somebody.
What you said, Dr. Rachita, can you
I
mute?
think
Yeah.
everybody should teach because whatever I am today is because of my teachers. And therefore, I feel whatever knowledge I have, I should impart to everybody because I cannot take my knowledge and go up. And our teachers were really so good. And even today, if they have any work, they just pick up the call and tell me, Madhuri, you do this for me. And I'll still do it for them. It's how many years now? I'll complete 50 years in 2027 for joining MBBS. So still, our teachers are so good and they still rely on you. They don't say, oh, you're now we don't know this, that, and all. So I have even Dr. Praveen Matre, he writes so many papers. He'll always send it to me for correction. He'll say, you correct, and then I will upload it. That way it is. But he was one of the persons who really taught us so much that it was really, and all our teachers are good.
It's a blessing really to have good teachers.
Yeah. I mustn't have read any books. I mustn't have read many books, but we learned only from our teachers so much, Does that?
Thank you, everyone, and wishing you a very, very happy New Year. May 2026 be very happy and fruitful for all of you. Thank you.
Same to you. Chalo.
Yes,
Thank you, ma'am.
and
Thank
Thank you,
you
ma'am.
for giving us the opportunity.
till
Thank
we
you.
meet again,
Thank
our
you.
next webinar is Perfection Series 9.0, January 7th. We will be speaking on a very important keynote by Dr. Pratik Tambe on the obesity epidemic in fertility practice. So tune in on 7th January and listen to a very exciting lecture dealing solely with obesity. So bye and see you in 2026.
Bye. Good night, everyone.
Thank you.
Thank you, ma'am.
Bye. Good night, madam.
Papa.